HRR mutations are patients which will be around 20 to 25% of patients where PARP inhibitors and possibly a platinum may work. 8 or more than 8 in 69. But they did not have much information as to what was the visceral metastasis status, what was the PSA, and what was the response to ADT, what was the time post ADT progression in these CRPC patients. HRR status, so again around 25% patients were HRR mutated in both arm, 26% in pembrolizumab plus olaparib arm, whereas this was also somewhat met in the HRR mutated subgroup with a hazard of 0.69. So just as what Dr. Vamshi was saying, that BRCA mutated you had a very good advantage, but in the HRR mutated you had some advantage. But this was a very small subgroup analysis probably which is applicable to only 25% or 10% patients. In the PDL1 positive or negative, there was absolutely no difference in the outcome. If you look at the overall survival, again, there was no difference in the overall survival, 15.8 months versus 14.6 months in both the arms. And here too what we see that the BRCA mutated subgroup, the overall survival, what we see that the BRCA mutated subgroup, the overall survival was better with a hazard of 0.52. And the only other subgroup which had better overall survival was North American patients, probably because they have better access to other treatment options. Again, PDL1 positive or negative, there is no difference. And HRR mutated, again, just as Dr. Vamshi was saying, the advantage, OS advantage had gone. So the PFS advantage was there, but the OS advantage was not there in the HRR mutated subgroup. If you look at the other secondary endpoints, time to first subsequent therapy, this was also not met. It was almost equal. And when we look at the subsequent treatments that the patients had received, 48% of patients, around 45% of patients did not receive any subsequent therapy. And olaparib or PARP inhibitors, which are important treatment options in BRCA mutated 10% patients or HRR mutated patients, which are 20-25%. Here also we see that this treatment was not given to the opposite arm, that is the control arm. If you look at the response rates, so yes, response rates pembrolizumab or olaparib based combinations. What is my critical analysis is that I would compare this study with the PROfound study. And what I see that the trial design was very similar to PROfound except the patient selection. This was an absolutely molecularly unselected population which was included here, and there was no information on the MSI and TMB status. Also, key prognostic factors were not included. Patients were well treated. They were 99% were exposed to docetaxel, whereas in the PROfound study almost 65% were exposed to docetaxel. Post-progression treatment was inadequate, just as I said, and there was no PARP inhibitor in the control group. 25% would be having a HRR mutation even in the control group, but yet there was no OS benefit in the treatment arm, whereas there was a significant benefit in PROfound study in both cohort A and cohort A plus B, if we remember. Subset analysis did confirm that the similar benefit of treatment was there, which was driven by the HRR positive and BRCA mutation subgroup, just like in the PROfound study, and toxicities look similar. So Monday morning practice, my key takeaways would be metastatic prostate cancer, send germline mutation for all, and NGS or somatic mutation panel, including TMB, MSI, HRR in the affording patients. Pembrolizumab plus olaparib, it is costly, it is potentially toxic, and we cannot use this in an unselected population in today's era of precision medicine. PDL1 is not a good biomarker for immunotherapy in prostate cancer. There is no use of doing PDL1, and we must try to expose our patients to multiple treatment lines, including cabazitaxel and radiopharmaceuticals for best outcome. Thank you for patient listening.
Thanks, Dr. Vivek. Now I invite Dr. Nandini Menon from Mumbai, and she will be presenting abstract on early results from a phase 1 multicenter trial of PSCA specific GO-CAR T-cell in patient with MCRPC.
Good afternoon, everyone, and thank you for giving me this opportunity. So the abstract that is allotted to me is the early results from a phase 1 multicenter trial, which looked at PSCA specific CAR T cells and metastatic castration resistant prostate cancer. This was a multi-center trial from various centers in the US, and was presented as a poster in this year's ASCO GU conference. So just a little background, basically CAR T cells, like we all know, are T cells from a patient which are isolated and genetically engineered to express a protein that targets antigen on the tumor cell. And then these T cells further have properties of expanding within the body and then circulate and attack all the tumor cells and lead to an immune response and lead to a control in the disease. So various antigens have been looked at for target. As a target in prostate cancer, they looked at PSCA, which is a prostate stem cell antigen. And to improve the function of these CAR T cells, they are engineered to have certain co-stimulatory molecules which enhance the T cell proliferation and allow the CAR T cells to expand within the patient's body. So this study included the administration of this drug called Remidusib, which was supposed to trigger, it was a switch to these T cells to enhance their potency and keep them persistent in the circulation. And this was a phase 1, phase 2 study which was looking at this particular CAR T cell in prostate and pancreatic cancers. So we focus on the phase 1 dose, and this was a cell dose escalation study to look at the maximum tolerated dose. The phase 2 is not yet started. So they included metastatic CRPC patients who had failed 2 prior lines of therapy, including an androgen receptor antagonist and a taxane. And they excluded, of course, patients with unstable bone lesions, coagulopathies, cardiac dysfunction, or active or symptomatic CNS mets. The primary objective of this phase 1 study was, of course, safety and tolerability, that is to identify the MTD and dose-limiting toxicities, and to get a dose for the phase 2 part of the study, that is the recommended phase 2 dose. And they also looked at characterization of clinical efficacy, pharmacokinetics of Remidusib as part of the secondary objectives, including biomarkers, which looked at T cell expansion within the body. So what they actually did was they gave lymphodepleting chemotherapy, prepared the T cells, CAR T cells, and then these CAR T cells were given at the dose of 5 into 10 raised to 6 cells per kg of the patient's body weight. In addition to these CAR T cells, 1 week after the CAR T cell infusion, Remidusib was given at the dose of 0.4 milligram per kg. Here there was a dose escalation. Patients either received single dose of Remidusib or they went on to receive up to 30 doses of Remidusib in the 3+3 study design. So 8 patients' data has been reported. These were patients that were recruited up to September 2022. All 8 received the CAR T cell dose. 3 patients received, in addition, a single dose of Remidusib, and the remaining 5 received multi-doses, which ranged from 1 to 30. So since this was a phase 1 study and looked at safety as the primary endpoint, these were the major toxicities that were noted. So the most common toxicities that are expected are myelosuppressive events because of the lymphodepletive therapy before you give the CAR T cells. But in addition, there are certain toxicities of CAR T cells that are of importance, like the cytokine release syndrome, which is a known toxicity of CAR T cells and was also seen in all patients here. Most of them were grade 1. Only 2 patients had grade 3. Immune-related neurotoxicity syndrome, also a known toxicity of CAR T cells. Only 2 patients had it, 1 grade 1, 1 grade 4, but both resolved. And there was 1 death because of neutropenic sepsis, which was considered a dose-limiting toxicity. So this was the secondary endpoints looking at the activity of the cells. So they had a PSA 50% response at day 28, that is a decline of PSA to 50% of the levels in 3 patients out of 7. And these are the data available till now on the RECIST responses of these patients. So 1 out of 8 had a partial response and of stable disease for more than 9 months. 1 progressed, and 2 patients had not yet reached the imaging time point in the trial. And as they looked at biomarkers and the activity of the T cells within the patients and how they expanded, these were the T cell expansion that happened. So these were the copy numbers of the T cell in the first week. And when they administered multiple doses of Remidusib, which stimulated the T cells further, these were the re-expansion copy numbers. So the authors concluded that this product, that is the T cell product that they have designed, targeting PSCA, had good evidence of biological activity and known toxicity like other T cells previously reported. Also, they said that Remidusib, which they are administering as part of the trial, induced activation and proliferation, and they were planning to escalate further to increasing the dose of Remdesivir to more than 0.4 milligram per kg, and also escalating the CAR-T doses. But there's an update. This study now is, although ongoing, has stopped recruiting patients further because of the dose-limiting toxicity. It is not very clear whether it is the same death due to FN that was the dose-limiting toxicity due to which this study has been the recruitment.
Thanks, Dr. Nandini. Now I invite Dr. Deepak from Indore, and he will be speaking on ANZUP 1603 trial.
Good afternoon. So the study is therapy trial. It is a lutetium PSMA therapy versus cabazitaxel in metastatic CRPC patients who have progressed after docetaxel. This is the overall survival result after 3 years of follow-up. So this was an open-label phase 2 multicentric randomized control trial, and patients who are metastatic CRPC patients who have progressed on docetaxel, rising, and all patients underwent PET imaging and a PSMA PET. PS0 to 2 patients were taken, and patients with FDG positive, but PS more than 50% objective response rate. These all were higher with lutetium overall survival as compared to cabazitaxel. There is another study, which is phase 3 study, which was published in NEJM last year, Vision trial, that included patients. That was a comparison between lutetium PSMA versus the available standard of care. So there was no available standard of care at that time. The available standard of care was either bisphosphonates, denosumab, steroids, palliative care. So that study has shown a survival difference of about 4 months, 11 months versus 15 months. And that study included higher number of patients, about 800 patients. So these two studies, they conclude that lutetium PSMA therapy as a third-line treatment is a very good option. Thank you.
Thank you, sir. Now I invite for last abstract presentation Dr. Mukul Rai from Mumbai, and she will be presenting a talk on phase 2 double-blinded placebo-controlled trial of prostate in oligometastatic prostate cancer.
Good afternoon, everyone. Thank you, organizing committee, for giving me the opportunity to speak. So I have been presented with this abstract, NRG GU011. It is a phase 2 double-blinded placebo-controlled trial of prostate oligometastatic radiotherapy with or without androgen deprivation. It was presented in ASCO GU 2023 this year. So a little bit on the background. There is no clear standard of care for biochemically recurrent prostate CA with PET detected oligometastasis, but normal on conventional imaging. So the phase 2 trials show that SABR, stereotactic ablative body radiotherapy to the oligomets may delay cancer progression and initiation of ADT. So ADT plus RT prolongs survival in locally advanced prostate CA and in conventional imaging metastatic prostate CA. However, there is a knowledge gap about the time and the benefit versus toxicity of ADT with SBRT in early OMPCs. So I searched on the NCCN guidelines, and I found there is no clear-cut guidelines in the NCCN for the oligometastatic prostate CA detected on the PET but normal on conventional imaging. Though there's a point that ADT for metastatic castration-sensitive diseases, they say that ADT with treatment intensification is preferred for most patients with metastatic prostate CA. So this study aims to evaluate the impact of relugolix when combined with SABR in oligometastasis. So mechanism of action of relugolix is that it allows for rapid testosterone recovery, and it has lesser cardiovascular events, that is 54% less compared to leuprolide, and therefore it is hypothesized to have low late ADT toxicities. So a little bit on the theoretical benefits of radiation cancer, similar to therapies like with degarelix, but degarelix requires a subcutaneous administration. Hence, it is less burdensome therapeutic option for patients who otherwise may need repeated clinical visits. as PSA doubling time less than 12 months versus more than or equal to 12 months. Sensitive prostate cancer, out of which the Oriole and the STOMP trial are the landmark trials in this category. The conclusion of this paper was that role of RT in systemic prostate cancer has historically been limited and palliative in nature, but the recent studies show a value of radiation, especially metastasis-directed SABR in patients with limited metastasis. And this effect is noted in both hormone-sensitive as well as hormone-refractory prostate cancer, along with a significant improvement in biochemical and radiological progression-free survival. So thank you for your kind attention, and thank you to our patients who are our greatest teachers. Thank you.
Thanks, Dr. Mukul. Now we come to close to the abstract presentation in the session on systemic therapy.
Get me wrong, I do agree. CT scan wise picking up metastatic disease and PET scan wise picking up metastatic disease, they may have a different biological behavior. But this is a good example to convince our ethics committee to allow these kind of studies. Think about stage 4 and you say, hey, I'm not going to give you ADT. That was the design. Only give RT and RT plus, it was RT plus ADT. ADT and ADT for 6 months. Impressive. Not giving ADT beyond 6 months, and we debate here when to stop it. And I think, sorry, urologist, we keep debating. Once you start ADT, either you orchidectomy or still CRPC, it continues. We never stop it. So that was a very good design, to have it, because we debate that we need to stop it early, not necessarily we'll need for 5 years, 7 years, which we keep giving. So interesting design. How to implement will be a challenge. How someone will take this project further, that will be a challenge. I didn't see that where it was done, which place. And the drug is very good. Oral, we are all looking for. I wish we get oral. So, but I think so. Orchidectomy remains, I think so, easiest, and most of our patients they do that, take that. Coming to a presentation for cabazitaxel versus lutein PSMA, I think so. PSMA lutein therapy is going to come. It's going to keep creeping. We have seen now 2 data, looks promising, looks that it will come in some form and some combination. Only it's bit more toxic than what we have thought about, and same is in that clinic, that trial, the previous trial which was there. But response was impressive, 40%. That was the response in the previous study. So looks here, they interpreted a non-inferior, number was too small to interpret that, but curve looks good. And if something is as good as cabazitaxel with the similar curve, and you give once in 6 weeks, most likely we'll choose that. Looks so, lutein PSMA will keep creeping in. That's the way we look for. Phase 1 CAR T cell, we sincerely hope. We are struggling with CAR T cell in solid tumor. Doesn't look like, we have some leads somewhere we keep seeing, but not those leukemia responses. We have not seen those leukemia responses that going into CR, except once in a while we have heard that. Pembrolizumab and olaparib, again here looks like olaparib is in. We'll keep debating where we are going to use. HRR, BRCA1, all combination. Immunotherapy is struggling. Again, we are not able to see in prostate cancer, immunotherapy really showing something, replace disease, and can we treat like that? Thankfully, sanity prevailed and we say, no, give systemic therapy right now. Wait for 6 months and then, we'll see it again. But majority of the site, it will keep coming, because we have seen with this PET based diagnosis of metastatic disease that those biologies are different. These patients, they will have metastatic disease, but a group of them keep doing very well. And that is where we want that they shouldn't grow. So we will have those struggles, that how we are going to treat them. Lung cancer, not lung cancer, 2 randomized trial in oligometastatic disease with local treatment with radiotherapy. Positive, they had to stop it because it was so good. 3rd one in lung cancer, it was so good. But the problem is that they're competing with the systemic therapy. So in lung cancer, by the time the trial happens with gefitinib, osimertinib is there. So again going back, so lung trial again was stopped because of the PFS was so good with adding the local treatment. So DSMC, they didn't, data monitoring committee didn't allow them to continue that study. It is doubling of the PFS.
And one more minute. Now that balances. One surgeon is enough for all. Yeah. So there are 30 minutes, 8 abstracts. I am going to be very crisp. I am not going to show all those curves because most of the speakers have eluded the data. And what you have done, the organizers, you have already given the expert comment, so we know the answer, right? We know the answer. Dr. Kumar Prabhash has done a fantastic job. So we are going to discuss what we actually do in our clinics. So we'll start with the case quickly. This young male, 58-year-old, with a family history of cancers, with well-controlled comorbidities, presented with no urinary symptoms, and the PSA was 11, biopsy was Gleason's 4+3, group grade 3, and the lesion was a little bit touching at the capsule, extraprostatic extension. So what all the investigations when such patients comes to you? Because we have been practicing for more than, say, 4 decades, where the investigations have been improving. And those cases which have been labeled as a locally advanced, now if you add a PSMA, suddenly you upgrade those patients. But those patients who have been operated years back come for follow-up, then we really have to ask ourselves whether we are over-treating them by over-investigating them. So what are the investigations you judiciously use for the patients in prostate cancer?
So in this patient, I would like to jump directly for the gallium PSMA PET scan instead of doing conventional. Apart from the, when I do PSMA, I do DRE, and if it's because in my mind, I may treat him surgically. If it is resectable, then PSMA PET will answer my all staging purpose. The purpose will be served. Or else bone scan with MRI with the CT.
Okay.
MP MRI and the CT, or MRI pelvis, that will tell us the lymph nodes.
Okay. Kulkarni sir, so why I mentioned 4 decades, because within the span, we have senior surgeons sitting in the audience. And Mike, please, there.
Well, thank you, Bharat. I agreed that we started in 77 and now 46 years. Of course, that time we had only bone scan. We didn't have anything. Then came in other scans which are F18 and other things. In between, we have been believing in whole body MRI was another good way for bone metastasis. Having said that, PSMA has revolutionized completely, even in Europe for that matter.
Yes.
That non-metastatic CRPC is going down because they were all actually metastatic CRPC, if you recollect that. So I think PSMA scan is very much, although of course the cost is a little issue, but I think in the long run, 25,000 or 20,000 is really not much. So I think we shouldn't make a cost as an issue rather than, the only thing which we're talking about a PSMA PET scan is today even to diagnose the primary disease.
No, but
That's going to come up. That's going to come up. But I think PSMA is the right way.
So you agree that PSMA. So Dr. Kumar Prabhash has rightly mentioned it's a systemic disease. You can't do without the systemic therapies. So that is why PSMA is very, very important. Now burden of disease we discuss as per we'll come to that criteria because there are only 30 minutes and otherwise it will go on surgery only. I have to talk about CAR-T. So this was the PSMA scan, no? Don't ask me too many questions. We have to finish it.
It's very
so
clear.
to the surgeon, would you like to operate this case? Only one lesion. That is because on the
first
PSMA scan.
paper which was discussed, surgery in the oligometastasis. My take on the surgery, if it is a T2 disease in the PSMA scan, I don't know what is the report exactly and what is the examination. Solitary mets, and what about the primary disease? But in the examination, if I am okay with the
It is
plane,
operable. Primary is
yeah,
operable.
or the planes with the rectum are okay. I am not very much concerned of the neurovascular bundle involvement, and the disease is not going into the bladder.
Including the systemic therapy person, even the radio imaging persons can discuss about these scans. One odd cases, sometimes no, we end up in saying non-metastatic disease. The scan must be discussed in detail whenever you see some, when you don't expect to have metastasis and you see something, the scan needs to be discussed.
Primary should be treated if
Yes.
we are not harming in the sense
Yes,
of no
very
rectal injury, no incontinence for a long time,
Very
maybe
important
patient.
point.
So
that is-
we should go for that.
Yeah, this is a very important point. If we are not harming, then this modality needs to be discussed. Now, surgery versus RT. So this abstract is actually for another purpose. So there are phase 3 trials where the RT in oligometastatic setting has been discussed, Stampede and one more trial, where it has actually shown benefits. So when we have a radiation modality of treatment in this setting, whether we should prefer surgery or radiation, to the radiation oncologist. First you and then Dr. Parneet can.
Thank you. I would like to ask the surgeon, you didn't ask for an MRI. You said you were not going to harm rectum, so I'll operate.
Yeah.
But if you have extra prostatic extension, the margin comes positive, again you'll send it to me. That's
No
what-
worries.
Again, after that, if small met is there, again you'll send it back to me. So why operate?
That based on why I am discussing, there are patients, anecdotally, we have been seeing those who are surviving.
What do you want from me? You
No,
tell me.
so how would you treat? Whether you treat with
Of
systemic
course I
therapy
will do
first,
radiation,
upfront radiation, or
Of
you?
course, I will do, it is
Fair
a
enough.
favorable intermediate. You
So this
said
is the
because
oligometastatic
it's a
single
bone
lesion.
met,
Single
It
lesion,
is
high
it
risk
is a
disease.
One lesion. One lesion, he showed.
Extra
it-
prostatic
So
extension.
the question is, would you like to add something upfront, or you would straight with the RT?
It is metastatic, I would like to
Yes,
use
yes.
ADT,
Perfect.
okay, at least 1 year.
1
And-
year.
Yeah, and I would do radical radiation therapy.
Okay, anybody wants to differ? Vivek,
Yeah.
and then
So
Dr.
I
Parneet.
think, the debate is coming nowadays because we are just extrapolating our facts.
Ajay?
Yes, sir. I also agree with the Vivek, sir.
So basically-
response duration will be around 3 to 6 months.
Yes, so basically everybody wants to start with the systemic therapy, that is ADT, and then wants to see the response whenever up to 1 year, maybe 6 months, 1 year. I'm coming to that.
Oh, what response?
Okay. What response? Vivek, you started. What response? Biochemical, radiological, because Vamshi clearly mentioned most of the time we end up in following with the
So
biochemical.
I just want to ask my radiation oncologist why he is
See, Vivek,
waiting
you
for 1
answer.
year.
You
What
don't need to
response?
No,
This is
I
going to
will
be-
give.
So
what
you
I
you
will like-
said you want to wait for 1 year. I want to ask, so why are you waiting
No,
for
no,
1
I
year?
am
For
not-
what?
No, he's mistaken me. I am not saying wait for 1 year. I said treat locally. If you want to give as a neoadjuvant,
So-
it's okay.
Correct, sir. So we can go after 3 months also. We can go after 6
So
months
Vivek,
also.
but what
Dr.
response
Vamshi
time?
mentioned in his center
One-
they are starting after 2 weeks only of AD.
Vivek, so you are saying 3 months also we can be treated. So everybody agrees that at the 3 months also we can treat if the depth of response. So main idea here is that we can't do without ADT, and that is what the next abstract is, where in oligometastatic setting they tried the feasibility of not giving ADT. I think we are not there to avoid ADT. It's good thing that we have an oral agent where they tried for 6 months. Something which we have tried in the past is intermittent ADT, where you can, but again, compliance of the patient is very, very.
Only for recurrence.
Oh, yeah. So
Not-
what
Sir,
I'm
what-
saying is
what
that has
actually-
been tried before. 6 months in a metastatic setting is not acceptable thing. One has to be on the ADT in a metastatic setting.
For upfront, we don't have.
No, for this.
Sir, actually what time gives us is a test of time to test the biology of the disease as well as the metastatic site to see whether it is actually an aggressive disease which is progressing or not. And 5 to 10% of patients we are going to get such kind of an aggressive disease.
Vivek, I differ with the other Vivek that it will not progress on ADT. This is small disease, we've never seen progression upfront.
So-
Castration sensitive.
So that is where our surgeons also say these patients are going to live for 10, 15 years. Some of them. We don't know the biomarker, and that is why not to operate. So we'll not go into that debate. So that is why they provide that modality also. But we don't have a level 1 evidence. I don't know. I have to say the surgery in oligometastatic setting. So you have asked the question to him, but I am not answering. Biology of the disease, we yet not there to know what is biomarker, no, what biomarker can tell us that this patient is going to live longer. And surprisingly, we have patients who have been operated in the past and they do well. The modality was not there to detect them in the, maybe they were the oligometastatic disease. But yes, I'm not here to support the surgery. But the main thing is, this is a disease where discussion of all the modalities together is very, very important, including the patient knowing the pros and cons of the modalities. So we'll not go into details of this. So I have already discussed this. These are the trials. So in metastatic setting, the space is getting crowded with the French group IGR data of 3 modalities: chemo, abiraterone, steroids, and now you also have questions. Okay. For the surgeon,
for the medical oncology.
for the medical oncologist.
You said you will give novel hormone agent, I agree with it, but will it be treated indefinitely, or you would like to restrict ABI at 2 years for this patient? Only one bone met and prostate primary. So it's purely an oligo.
Yeah,
So the second abstract, maybe that oral.
Looking at
GR.
oligometastatic curative setting, I think 3 years
Let me
time.
complete the question. ADT indefinite, I mean the GnRH analog.
I think, sir, because it is the oligometastatic disease and if we have given definitive RT,
Yes, we have
and
given
if
definitive
everything is
RT.
in control, then I would want to stop at 2 to 3 years.
Both ADT and ABI at 2 years.
Yeah, I would not want to use abiraterone. I would use rather an enzalutamide or an apalutamide or a darolutamide.
Enza or AB, whatever.
Yeah.
And any novel hormone therapy plus ADT at 2 years. You agree?
Yes, sir.
So this trial, where they looked at placebo versus 6 months of GnRH oral antagonist, and after 6 months, we maybe getting the data. So he said 3 years. There is no data for 3 years also for oligometastatic. Once metastatic is always metastatic. But yes, on a individual case basis, you can discuss based on the toxicities of ADTs.
I think you can extrapolate from the high risk prostate. What they are doing is ADT plus
Exactly.
ABI for
So
2 years.
extrapolation from high risk,
High risk non-metastatic prostate.
non-metastatic. I think in our clinic, as the debate goes for surgery also, we do take the decision based on the patient's tolerance to these therapies. And if the patient is doing good, we really fear to stop that particular therapy because nobody wants to jump again from a controlled disease to a metastatic setting. But yes, as he said, you can take a decision, individual decision. So as this space is getting crowded. We have chemotherapy, newer androgens, steroid. Now.
I think, yes. So we did not add ADT to any patient. We said that we are giving RT for oligometastatic disease because we want to delay initiation of ADT. And only when
have one in Mars.
No, British Columbia group is a big group. We don't read that. See, they have done, I will treat this as high risk disease, and then they've stopped at 1 year. And when it recurs, they have used intermittent ADT,
I agree
and
with
they
you.
have done well.
That I agree with you. So my apology for that comment.
That is why I said 1 year is good enough. When it recurs, we will again restart.
Okay. So basically, as sir rightly said, so again, we are not discussing the circulating tumor DNA mutations to stratify this thing. So when that debate will come, so we'll stick to the next abstract. So Daro plus ADT and chemotherapy together.
And patient factor is also important. How is the patient young and what is the comorbidity? If patient is elderly having a comorbidity, then I will not prefer using a triplet regimen.
So this is very important point, as you mentioned, the comorbidities and patient factors. And we have recently started the geriatric clinic. And this is a disease largely of a geriatric age group. The assessment is very, very important. You have, why the assessment is important? It is not for the overall survival of PFS, it is to reduce the toxicity. And we are talking about a lot of toxicities of ADT. You are trying to add the newer anti-androgens, which is the most important factor.
Comment which I have, cognitive functions.
Yes, very important.
That's the most important thing
Yes.
today. I think we have never looked at that. And this is the time for us to look into that.
Yeah, so Not as a geriatric assessment, we have been doing now at a spinal level assessing the patients, but now the cognitive function is a part of geriatric. The ultimate survival. A 60-year-old male with no comorbidities operated by robotic surgery, followed by 2 years of adjuvant ADT, followed regularly for 3 years, post-ADT, slow rising PSA. So in the clinic, we get patients with very slow rising PSA where actually a few of, this is again anecdotal, we have followed them and nothing we have added and they have done actually well. And that is why all these questions come. So for a slow rising biochemical failure, what are the investigations? Maybe no surgeon can add over here. Only you answer. For all comers. So quickly, I'll short it. In the trial, they have come down to the benefit to only BRCA patients. This is another trial, Propel trial, and 2 days back, the FDA granted permission to this combination, and this combination is abiraterone and olaparib, and talazo is talazoparib with enzalutamide. So there was no overall survival benefit in statistically significant, but yes, based on the PFS and OS benefit in BRCA1, BRCA2, not in all HRR mutation. Forget about those BRCA1
patient.
So will you use upfront or will keep the PARP inhibitor in sequence?
What I believe is, sir, is that the PARP inhibitors, we need to bring them early on into the management in the selected subgroups of BRCA1 and BRCA2, whether it is breast cancer, whether it is ovarian cancer. So if it is BRCA1, BRCA2 positive, I would want to bring in the PARP inhibitor.
The PARP inhibitors upfront. Now quickly going through your trial, Vivek, that this stopped because of futility. But again, you clearly mentioned the benefit was in the BRCA group. So why to use immunotherapy? Use only PARP inhibitor over there.
I totally agree that using the trial design was not correct, and I don't think that there would be any advantage of adding immunotherapy to BRCA positive patients. Probably they need to do the study. They should have had an only olaparib arm to really prove that pembrolizumab was adding on. So in the unselected group, probably never add immunotherapy, even only with when they have mutations TMB greater than 10 or MSI high.
So message is very clear. When a metastatic prostate cancer comes to you, you have to counsel them for genetic counseling. Don't advise them BRCA testing. Send them to the counselor. It is the counselor's job to counsel, and then with all information in mind, the patient has to decide about the genetic testing, because we have molecules available which are patients are getting benefit. Geriatric assessment is very, very important. Now the showstopper of the today's meeting is CAR-T. Nandini, Dr. Nandini is there. She has presented the data. Now everybody is aware about the CAR-T. These are genetically engineered the immune cells which are re-injected in the patients, and they look after the refractory disease. It has already achieved success in hematological malignancy like ALL and lymphomas. I have recently met a patient who has undergone CAR-T therapy 4 years back. So it has changed the game in leukemias and lymphomas. So we are seeing in solid tumors that this could. What is the idea behind it? The immune cell has to have a target, single target. Now what happens if you target at one target is achieved? Again, the cells are very smart enough. But in leukemia, CD19 is the target. In myeloma also now we have genetically engineered CARs coming from abroad. We don't have one person from the IIT has designed this CAR-T vector, and 15 patients data is already out. This is first India-made indigenous CAR-T cell. And the data looks promising. They have already moved into phase 2, which is designed, I think. The adult patient is also recruited. Initial data was from the pediatric. So immunity. So immunotherapies are evolved in that way only. We used to kill the tumors with chemotherapy, but in spite of getting the excellent responses here, this is the future. We have to enroll our patients in the clinical research trials. Fortunately, we as an oncologist community coming together on various platforms, and we should discuss ongoing clinical trials with the patients. Enrolling on the clinical trial is something which NCCN or any other guideline always recommends. So do look around yourself that there are clinical trials and your patient is fit. We must enroll those patients on the clinical trial. Thank you all my panelists to having audience. Before the lunch, the hall is...
I would now request Dr. Vivek to come and coordinate and start the session, sir, please. And apologies for this change.
Good afternoon, everybody. So we've had quite a heated prostate session, and let's see if that continues with kidney cancer as well. So for our first session, our chairpersons, Dr. N.P. Gupta sir and Dr. Jagdish Kulkarni sir, please, I'd like to invite you, yes. And is Dr. Pathak here? Dr. Hemant Pathak? So I think we informed him. He must be on the way. So our first speaker for this session, Dr. Mayank Agrawal, renal cell carcinoma in transplant recipients. Is there a role for screening?
Slides, please. Good afternoon, everyone. I would be discussing about the role of screening for renal cell carcinomas in patients who undergo renal transplant. So I would be discussing the latest evidence which was published in Journal of Clinical Oncology by the researchers from University of Texas. Patients who undergo renal transplant are at increased risk of malignancies. The most common ones are skin malignancies. The other ones are either infection-related or infection-unrelated. The renal transplant recipients, because of developing malignancies, are at demerit because the survival decreases. And malignancies in transplant recipients is one of the leading cause of mortality. The most RCCs which arise in renal transplant recipients are from the native kidneys, but they can also arise in the allograft. As already discussed, they affect an old paper. This is the paper which studied almost 1,000 recipients, and they found that the gains in the life expectancy was less than 1.5 days at relatively high cost. Compared with no screening, the absolute gain in survival is only 2 deaths from renal cell carcinoma avoided per 1,000 recipients if the patient was screened annually for 62 years. However, the study also found that the cost effectiveness is there in the patients who are high-risk individuals, especially the patients who have acquired cystic diseases or who have a family history of renal cell carcinoma or suffering from familial syndromes like VHL. In another systemic review of clinical practice guidelines published in 2017, looking at the guidelines which specifically focused on the transplanted organs, kidney, and the cancer screening was done for kidneys, only one guidelines, European best practices guidelines, recommended screening by ultrasound. Rest of the guidelines did not recommend screening. So to conclude, screening for RCC in renal transplant patient is an effective tool for early diagnosis and to reduce RCC-related mortality. However, it is not cost-effective. It may be considered in high-risk individuals. I would like to thank my teachers and the organizers for this opportunity. Thank you.
Production and with aims of which could predict intraoperative adverse events and internally validate that model. We explored the possibility for such data from Vaticuti Collective Quality Initiative database. So VCQ is from 9 countries, and it has for partial nephrectomy about data of about 3801 patients. So using this database during past 1 year, we had published 4 papers, including this one, and 1 paper has been accepted recently in European Urology Oncology. So I just wanted to show this because maybe there were some limitations of this VCQA database, which we have highlighted in other studies and may not have been highlighted in this particular article. So data for intraoperative adverse events was obtained from VCQA database by combining the 3 parameters separately reported into the database. First was intraoperative complications. Second was conversion to radical or open nephrectomy. Third was intraoperative blood transfusion. So the database has
64 and the Emotion 10 trial. So basically these two trials, they are randomized controlled trials. One was, both are with the immune checkpoint inhibitors, where a good number of patients were there, 994 in the keynote and 778 here. So the first one was with the pembrolizumab, 200 milligrams IV, when it was compared with placebo, and the primary endpoint was the disease-free survival. The risk groups were the intermediate and the high-risk group patient population with a PT2 high grade and T4 sarcomatoid PT3. These were the high group. High group were PT4 and any grade PN1. And the metastatic were NED. So basically these patients either synchronously or metachronously, they underwent a resection of their metastatic site. Metastectomy was done. The disease-free survival was, the hazard ratio was 0.63. And at 24 months, it was 78.3% for the pembrolizumab AM, and for the placebo, it was 67.3%. When overall survival, there was not much of significant identified. In the Emotion trial, it was 778 patients were included. It was with atezolizumab, and 1200 milligram was given to the patient IV every third weekly when compared with placebo. Here also DFS was the primary endpoint, and similar risk group profile was there for both the studies. Here the DFS was hazard ratio was 0.93, which was a negative trial, and there was not much of significant in the overall survival benefits also. So to discuss what the author mentioned, identified in the keynote 564 and in the Emotional trial, the lymph node invasion was one of the factors, poor prognostic factors identified for in the final histopathology assessment. For the keynote, it was the low proportion was there, 6% of 994 patients were there, but in the Emotion trial, it was 11%, that is 83 of 778. So this is a very high risk factor considering the overall prognosis of this patient. Hence, they would have an early progression even after surgery. The second was the complete metastectomy, that is a M1 resected with no evidence of disease. So it is also a poor prognostic factor, increased risk of early progression will be there, which a higher proportion was there in the Emotion trial, which was 14%, and in the keynote was 6%. So higher disease-free benefit in the Emotion than in keynote 564, but still theoretically we were not able to understand why there was not much of benefits identified the DFS. So the possible explanation what was unexpected findings were there, that 78% of M1 N0 disease included in the Emotion trial had metachronous metastasis resected, that is recurrence of disease occurring no less than 12 months after the primary nephrectomy. And the synchronous metastasis were 22%. So atezolizumab has little effect after nephrectomy, and that other factors may have probably the counterbalance the risk of progression among patients enrolled in both the trials. So to conclude, patients with lymph node invasion and patients with long-term metachronous M1 treated patients who comprised a greater proportion of patients in the Emotion trial than the keynote 564 might not benefit from the adjuvant immune checkpoint inhibitor monotherapy, but they might benefit from the upfront immunoimmunotherapy combination or the immunotherapy TKI combination as soon as there is a progression seen. So absence of benefit for the systemic monotherapy compared with observation in those clinical scenarios has been suggested, although with little evidence. So finally, to conclude,
what happened is we stopped doing cytoreductive nephrectomy for all our metastatic RCC patients. And that paper was done with sunitinib, and over the last few years, we've had a lot of more therapies that have been available. So we compared sunitinib with sunitinib and surgery, and on the other hand, the systemic therapy was only getting better. So there was in fact some evidence, or it was our thought, that back to just discussing a few points about Carmina, it included only intermediate and poor risk patients, whereas this study had good intermediate and poor risk patients. For Carmina, the accrual was very slow, and they did not even reach their planned accrual. And there were considerable shorter OS in Carmina compared to all the retrospective evidence that was available till then. Another shortcoming of Carmina was the median size of the primary was 88 mm and the median total tumor burden was 140 mm. So only half the tumor load in the body was actually contributed to by the kidney, and that is why the benefit of cytoreductive nephrectomy was not very apparent in such patients, and those receiving systemic therapy had better survival. So to conclude, upfront CN should not be overlooked, as this paper says, and it has a significant better survival regardless of whether you're going to use a targeted therapy or the immune checkpoint inhibitor. But you should not be doing it for all patients, obviously. Younger patients with fewer IMDC risk factors, no adverse metastasis, and better performance status are more likely to be benefited. And you'll get the best results if you do it on the right patient, at the right time, and the right place. So you need to select your patients properly. So this paper is probably just adding on to what we actually do. It is giving us some evidence, first time some evidence, that even in the setting of using immune checkpoint inhibitors, the IMDC risk stratification can still be used. Our poor risk patients, give them the immune checkpoint inhibitors. Intermediate risk patients, stratify. And for the good risk patients, we're anyways doing thank you.
Thank you. We move on to the next paper. Dr. Shayan Pal from Kolkata will talk on bone-only oligometastatic RCC patients treated with stereotactic body radiotherapy.
Good afternoon. Thanks, organizers, for the opportunity. So this is actually a very interesting paper. So we heard a lot about MIPS and MAPS in metastatic RCC, but we rarely get to listen to radiation therapy in RCC. So this is an article which was published from Turkey, the two institute of Turkey. It's a retrospective patients data. Bone only metastatic renal cell carcinoma patient treated with stereotactic body radiotherapy. So as we all know that, so there is a role of local treatment for metastasis in renal cell carcinoma. We have many articles published, and we have a systematic review also, and which says that the metastatectomy in metastatic RCC is for overall survival and cancer-specific survival. And we have consensus guidelines from Europe, and which says that the hyperfractionated radiotherapy can be used for metastatic directed treatments, and TKI can be given concomitantly with radiotherapy, and SBRT has a promising clinical effectiveness, and if there is a spinal cord compression, should be given after decompressing surgery. And they have also recommended SBRT for metastatic bone sites. So the thing is that there were articles which was published on metastasis-directed therapies, but there are no article which was published on bone-only metastatic sites. So there are articles which other metastatic sites, visceral metastasis along with bone metastasis, and because the bone metastasis response was also not published in many articles, because it is, as per RECIST criteria, is a non-measurable metastasis. So this study evaluated the clinical data of 54 biopsy-confirmed RCC patients who were treated between 2013 to 2020 in 2 of the centers in Turkey. The inclusion criteria was a histologic diagnosis of RCC on primary tumor, fewer than or equal to 5 oligometastatic bone lesions as per the definition of oligometastasis, and control primary tumor. SBRT fraction they had used is higher than 5 gray per fraction with a BED or biological effective dose of at least 90 gray. They have used an alpha by beta value of 2.60 because there was a conception that RCC is usually a radio-resistant tumor, but if we use high dose per fraction in SBRT setting, we can overcome this radio resistance. So the exclusion criteria was if the patient had undergone any surgical procedure for metastatic lesions, had functional loss due to fracture, or had any other type of metastatic lesion besides bone metastasis. So these patients, this is the criteria, patient's characteristics. Most of the patient had received systemic therapies, and many patients had systemic therapies before doing the SBRT, mostly TKIs and immunotherapy, and few patients have received TKI and immunotherapy both. And in few cases after SBRT, the systemic treatment was also, but only one metastasis, there is not much difference. So all oligometastatic sites, they behave similarly, but patients who were given with studies so far has been published, which
Metastatic RCC.
Good afternoon. I would like to thank organizers for this opportunity. I'll be presenting this paper on outcomes of radiation therapy plus immunotherapy in metastatic renal cell carcinoma, results from Canadian Kidney Cancer Information System. It was published in 2022 in Advances in Radiation Oncology by Eric Nguyen et al. Coming to the background of this article, immunotherapy is the first-line option for the management of metastatic renal cell carcinoma, and evidence has suggested that response to immunotherapy may be potentiated by radiation therapy due to the synergistic potential of combined modality therapy. Compared to conventional fractionation, stereotactic radiotherapy with high-dose radiation may produce immunomodulatory effects which enhance immunotherapy response and overcome radioresistance. It has been hypothesized that higher dose of radiation initiates endothelial cell apoptosis, which results in excellent local control, but this is not seen in conventional fractionation. So, purpose of this study was to evaluate outcomes in patients with metastatic renal cell carcinoma receiving immunotherapy and radiation therapy compared to immunotherapy alone. So, data were collected retrospectively from 14 academic centers across Canada between January 2011 to September 2019. In total, 505 patients with the of immunotherapy. When they looked at the results with a median follow-up of 13.9 months, 2-year overall survival was around 55 in a combined arm, and it was 66 in a immunotherapy alone arm. Though outcomes were favorable, but did not reach the statistical significance. However, time to treatment failure was 12 point with the focus on RT timing and clarifying appropriate dose fractionation based on immunotherapy agent. So my take, there's a significant heterogeneity in patient population and also in prescribing RT dose. More than 90% of the patients in radiotherapy arm had a brain and bone metastasis, which was poor prognostic factors. And nearly three-fourths of the patient had received palliative radiation with the primary intent of symptom relief, that is purely palliation rather than local control. And majority of them received very low RT doses. Optimal dose and fractionation, it has not been defined yet, but however, preclinical studies suggest that dose as low as 12 gray per fraction is needed to initiate immunomodulatory effect. And finally,
practice, I don't know amongst the audience who is doing this kind of treatment. Regarding the surveillance in renal transplant recipients, I think so ultrasound is very commonly available, and like a annual health checkup, ultrasound should be done in a post transplant patient, and I think so in India that kind of study is not a problem actually, that is a routine practice.
Couple of comments, as Dr. Gupta has clearly said, what is, and I endorse what his views are. Now, of late I'm seeing patients at Bombay Hospital where the transplant program is going on for the last 30 years. And in last 3 years, I have seen patients who had recipients, I mean, more than 15 years, 3 renal tumors in, these native kidneys. In other words, why it was not there before? Because the transplant, recipients are not surviving. As they are surviving more, this is as far as the RCC is concerned. There are other recipients who are also developing prostate cancer, lung cancer, and so many things. So it's going to be there. And I think with the transplant program, which is going on so well across the country, and now we are finding these patients, so we'll have to be more vigilant, and we will have to look into not only ultrasound, but something more than that, because the patients are going to live longer. So that's one take I got. The other thing which, of course, we looked at this cytoreductive nephrectomy. The debate is going on and on. Well, thank you very much for this new abstract which says there is a role for cytoreductive nephrectomy. We are reanalyzing and reinventing those things, that there is a place for cytoreductive nephrectomy. Having said that, oligometastatic, bone-only radiation, again, the radiation was never used as a primary therapy. It is always for pain relief. So I think the articles also clearly mention that the primary treatment plus, and as the immunotherapy is going to be the answer. Slowly, I don't know, so Dr. Gupta was saying that we might have not to do any nephrectomy either. So maybe the times have come where we'll have to look into these things. Thank you very much, and very good session, and very good selection of papers. The honesty of the people was good, in the sense those who were reported, especially if you see this article on, nephrometry, nephro score, 24%, as I saw, were converted into open surgeries. Honestly, I think that's very nice. Thank you very much.
Thank you, sir. We move on to the panel. May I call Dr. Bakshi, sir, to moderate the session. And the panelists, Dr. Kishore T.A. from Kochi, Dr. Anil Mandani from Delhi, Dr. Kumar Prabhash, sir, Dr. Amit Ghosh, sir, Dr. Puneet Raj, and Dr. Bhavin Visaria.
Thank you. So we'll have a brief discussion on the papers which were presented. Any specific questions from the audience is welcome. So we'll take one by one. And addition to this is the main organizer, Dr. Kumar Prabhash. There are 2 abstracts which actually need him, and hence he is pulled here. Thank you. So, as sir just said, there are 2 articles where they're on renal transplant patients where screening for renal cancer seemed to be important. So, we have been in cancer, and sir just made a comment that been seen some 2, 3, 4 patients over a long time. So, Dr. Kishore.
Line also recently it has come up.
Ganesh,
Okay.
can I make a comment?
Yes, sir. Please.
Most of these events are later in the transplant recipient. 99% of the times this patient doesn't see a urologist. He's been followed up with a nephrologist. Nephrologists are not cancer oriented. They would be simply looking at renal functions and moderating or modulating their therapy. That's one of the main reasons.
Can I just
Please.
put in?
Yeah, you wanted a comment.
First of all, I have worked in a very high volume center, which is the Oxford Transplant Center, for very many years. And the incidence of that renal cancer in transplants, in my experience, has been very low. That also is applicable in India. If you analyze the data that is already published data, whatever RC happens in renal transplants happens mostly in the non-Asian populations, in the African population. Okay. So I'm a little skeptic about the significant incidence of RCs in transplants in India. But even if it happens, I don't think screening is going to be a problem. I don't think it is going to be actually cost effective. It is not going to be cost effective. It is actually going to be cost effective, but for the wrong reasons, we are going to do a transplant.
I have a comment. Recently, we have noted...
Quick comment.
Especially in cases of...
To know that we are discussing this paper, I'm really delighted to know that this thing has happened. But if you look at the actual incidence of RCC in 2000, and they had a series of 2,000 patients in 20 years, 16 patients had RCC. So KDIGO guideline does not recommend routine screening. In EUA also says in high-risk patient. But for the first time, we Indians should recommend screening for recipient. It is not a big deal. Annual screening with ultrasound is not going to kill anybody. Just think of yourself as a recipient. Would you mind not having ultrasound every year?
Wait, is it recommended right now? No.
No, that's what I'm saying. Okay. This is the first time we should give recommendation.
So Puneet, you operate cancers. How often you get a reference? Have you operated one like this? I mean, I've been in TMH where there is no renal transplant, so I have no experience.
Patients are dying with cancer. But sir, but as such in India, every renal transplant patient is getting an average of 4 to 6 ultrasound every year.
So
by the nephrologist.
Saurabh, you said you have been seeing transplant in recipients, right? No.
Yeah.
Have you seen renal cancers in transplant recipients?
No.
Till now, I have done 5. All of them have been low grade. I have never encountered a...
All clear cell?
Yeah. All
one
clear
patient?
Cell, no really like high grade lesions I have seen.
These papers had a mix of mostly clear cell, then few chromophobe, and then papillary.
All of them.
If you can, I just have one point to discuss here. For transplant patients, like, is there a, like we are talking about screening, is there a particular category of immunosuppression or drug which causes more patients more prone to cancer? Like TAC is supposed to be a cytotoxic, and in patients receiving tacrolimus, the incidence of cancer is more. Mostly these are skin or lymphomas or leukemia. So, but these cancers can also happen. So, is there a particular thing, like if patient is receiving tacrolimus, you should screen more for that?
I don't think it is drug based in the literature.
No,
Dr. Kishore, anything? I think the immune suppression itself is a big problem.
Anecdotal reports of TCC coming with cyclosporin, that is, otherwise no, not much.
So again, coming back to one point raised by Jagdish Kulkarni sir.
Ganesh, can I make? So I think so now, whenever we have screening, the criteria for screening remains similar, and we need to keep putting, does it fit into it? Is it a significant problem? That's first. So that we need to say it. Second, that does it cause the kind of mortality what we're looking for? Third, do you have a test which can really pick up early to change the natural history of the disease? And then to show that if you did it, it did decrease at least the disease-related mortality. And that's why screening is a big problem. Which any disease you'll keep seeing, we know PSA story, we know breast cancer story. So be careful here. If in your
so this is a smaller population.
If your kidney transplant patient, if this incidence is too low, criteria remains the same. The test should be decreasing, it should be picking up early. You should be able to treat to decrease the mortality. No, those criteria, wherever you do, remains the same. You need to fit those criteria. I do agree. It's not a population-based screening I'm talking about.
Okay, I think we'll...
But if you have
Ganesh, one last...
they have more potential to develop other malignancies in the abdomen.
Go on.
It might be worthwhile to get an ultrasound for kidney transplant recipient.
Got it. This is eminence-based guideline. We say it, and I also do it, and that's fine.
Santosh, anything?
The recipient kidney which is already affected by CKDs generally don't get clear cell or chromophobe RCCs. There is a category of RCCs called as ACD, cystic disease associated. It's a dialysis associated cystic disease which occurs and then develops. That's got a specific morphology which is completely separate and different from conventional.
These papers had the RCCs.
That's a strange funny. I did not reach that.
I agree, but these papers had clear
The
cell
recipient,
chromophobe and
the
papillary.
donor kidney generally has PTL. Which are called as post-transplant lymphoproliferators. That's the commonest thing of lymphomas, because they immunosuppressed lymphomas are the common malignancies.
And I agree. And for that, there can be some argument about it that do you want to have a screening for post-transplant lymphoproliferative disorder? Because that's the commonest disease you have in that setting.
But that acquired cystic disease RCC.
I think we'll go on to the next abstract. Development and validation of a nomogram predicting intraoperative adverse events during robotic assessment.
About your ischemia time that is going to happen.
Sir, but don't you feel now enough discussions have happened on ischemia time? Ischemia time probably now is mattering when the parenchyma is as such in a not so normal state, or the recovery, the left out parenchyma after cutting the tumor is very less, or the left out parenchyma has got a problem. So ischemia time is also technically important in patients who have solitary kidney or a deceased or a semi-deceased kidney.
Yes, that is why the function is important. You see, it is not only the imaging and the radiography so far that we considered, it is important the duration of, the proof of pudding is in eating. Your ischemia time may be not 25 minutes, 20 minutes, 30 minutes, but what is the effect of that ischemia time as far as the recovery duration is concerned is very important.
1 minute before you. I mean, honestly, I have done a partial for 1 hour and patient is absolutely fine.
Because his recovery, what was his kidney injury?
It was less.
Yeah.
But so, I mean, we just keep on shouting about ischemia time, ischemia time. It's not, I was saying, not always important.
Yeah, in these situations, transient rise in the creatinine may happen, but usually they comes to the normal.
So that transient is also an AKI which comes back to normal with good recovery and healing.
Yes, one thing.
Probably.
Second,
Those who do not come back is what matters.
Right. So recovery of the left out renal parenchyma post ischemia. Kishore, what is your comment on that? You do a lot of partials.
I think, again, nephrometry score men.
Ectopic kidney, horseshoe-shaped kidney.
Why obese patient particularly? Because obesity otherwise should not cause anything.
No.
There is no literature data support on that.
Just my question is, like suppose we are operating on the obese patient.
On evidence basis, I don't think obesity stands anywhere.
Technically, sir, in obese patients doing surgery, lot of fat.
If you're doing robotic surgery.
Yeah.
Easier on the obesity
easy maybe,
side.
but yeah, it's not about only robot. Surgery per se in the obese patient vis-a-vis in the lean thin patient is easy. And
I think come to your specific point.
Yeah. So other factors also play important role other than the tumor specific factors.
Oh, that we discussed. Gopal, anything you want to say specifically?
Sir, regarding...
There are a lot of nomograms.
Yeah,
I think after yours also more will evolve.
Yes, sir. Definitely. So this is different from others because in this we have looked for intraoperatables. If you have patient's age, all the data from the 5.
My question was different actually. It was like, suppose if I am doing a very complex partial nephrectomy, today seeing your nomogram, should I totally give up on that? That's the question.
No. Sir, there is no...
It's basically to have a better idea of what amount of complication you are going to have and to counsel the patient.
It is just basically for counseling. Renal nephrometry score, even the scores of 12, it doesn't signify that we should abandon the nephrectomy. It is
but
just
it does say in the MD calculator that there is a 14% chance of urine leak and there is a 10% chance of some complexity. It does say that.
So, that we can counsel the patient accordingly then.
So that is what is in development.
Complexity. It does say that.
So, that we can counsel the patient accordingly then.
So that is what is in development and we can actually tell patients that this
I think we'll go ahead then. Identifying patients for adjuvant therapy for after nephrectomy. Let us initially have a small surgeon discussion and then take Dr. Kumar's view as what he sees in such patients later on, when they are not given probably or too late given therapy. So what we know is all these things: source, assure, S-track. And then I just put these slides because these are the therapies. Nivo cabozantinib has a role. Probably Randeep just told me that it is an upfront, you can give it in any patients. Keynote 564, I think lot of big time data and results were reported on that. So, sir, if you have these, okay.
No, no. I mean, I can comment on this.
Yeah, please.
For me, I don't think there is a role of any adjuvant therapy. There is evidence-wise, there is no evidence to prove that. And rationale-wise, there is no rationale in either giving ICI or sunitinib.
Okay, so...
Pembrolizumab does have a role to play.
I mean, it has evidence.
It has evidence, yeah.
So I have changed my practice to basically counsel the patients. So once I see that the patient has a tumor which is T3 or...
I'll just give a scenario.
Yeah.
I operate a IBC thrombus which is intrahepatic with a lot of hilar nodes which all come positive, Fuhrman grade 3, clear cell RCC.
Yeah.
What will you do post-op?
Obviously,
surgery is clean.
I would counsel the patient about the role of the potential role of pembro in this setting, and I will tell the patient that there is one study which is supporting this, and that also disease-free survival, not an overall survival.
When you have a half of your patient dying in next 5 years, there is a rationale that you want some treatment to make it better, that either they survive more or they live more or they live more without disease. So definitely there is a rationale that one should. TKI, I do agree, NCCN guidelines suggest there was a trial positive, 2-3 negative. Usually people are not so keen. Ganesh knows we are also not so keen in TMH when we were together. Coming to immunotherapy, 1 trial positive, 2, I think so 3 is negative. I totally agree. There are negative study. This trial, all updates has been positive. I don't know, it is a surprise for me. But this is similar issue in bladder cancer also, that there is 1 trial positive, 1 trial is negative. The positive trial this time got updated and presented in GU ASCO. And the difference in survival for PDL DFS is 12 months versus 50 months. Not easy to ignore those kind of data. So here also in kidney cancer, what I'll suggest that the discussion should happen. I'm not saying one has to give in every patient, but to say that discussion should not happen, meaning that we are thinking that that data which has come, and you don't have alternative unless you have it. For example, I say T3, all thing good, Fuhrman 1 perfectly fine. But what was suggested by Ganesh, in that trial, metastatic patient who had a arterial resection was also included. Then you will say, we have 10 nodes, you have removed it, T3 tumors, not easy to ignore. So having a discussion definitely should be there.
So maybe have a good counseling, have discussion and offer. Quick comment because...
What the patient has, and absolutely fine. I'll give you an example, and published from Tata Hospital, we had a lignocaine trial by Dr. Badwe sir, 3% absolute benefit, but lignocaine cost a few hundred rupees. This has got covered into so many places, including JCO with editorial. So you do have a cost also giving you where you want to use what. I totally agree with you.
Just a comment to Amandeep. Amandeep, this is not aspirin. In adjuvant IO, we will be discussing that in the next session, has toxicity. And there is a discontinuation rate of 20%. Discontinuation. So even if it is one
score, then one is objective, one is very subjective.
No.
I mean, the criteria are subjective. So I will operate the best of the prostate cancer patients and send the remaining to my radiation friend. So
but that's their job, isn't it?
We used to have a discussion long back, 10 years back in Tata Hospital like that. So it is that kind of logic. If I give him equal patients, he'll produce results which is quite good.
You can't. In the unfavorable patients, it is already proved that it doesn't work.
Okay.
So the surgeons are a privileged class, isn't it?
So there was a good deal of matching which was tried in this very large study. I agree with that, IPTW matching. Puneet, I don't know if you have gone into details of this paper.
I have gone into details,
there was a lot of matching, it was quite confusing.
I could understand a bit of statistical analysis, but not the whole lot of it. You know, there was something called multivariate confounding.
I also thought so. I mean, there was a lot of matching tried, but God knows.
What the gist was that they tried to evaluate, had both the groups been of the similar settings with similar criteria. So what would have been the results in that? So even after that, they found that the upfront cytoreactive nephrectomy was better in both targeted and TKI, targeted and ICI.
Reverse engineering. The target was decided, and we looked into that.
So what I think is that had it been like based on the IMDC criteria, you divide have a good risk patients, intermediate, and then poor risk patients, and then evaluate subgroup, do a subgroup analysis. That would have been probably a better thing.
Maybe. Sir, the question is for you, Dr. Mandani, sir. The fourth question. I think we'll end this abstract after that. So, will you change any practice which you do today, or you will continue with the same?
Absolutely not. I would try to remove as many sites as functionally possible and just observe.
Okay.
And if he has residual disease, then only I'll consider him for adjuvant. Otherwise,
No,
disease.
not adjuvant. This is upfront cytoreductive.
Upfront, apart from nephrectomy, as many sites as functional.
So the guideline says that upfront cytoreductive nephrectomy you should do if you are able to remove that as well as all the metastatic sites.
Right. So that is in a oligometastatic in a group somewhere which are there. So coming to the two radiation topics which we had, bone only oligometastatic renal cell carcinoma. So bone involvement is seen in 20 to 35%, and this was said in the presentation by Dr. Sayan. OS is higher with a solitary, and then as the bone mets increase, it goes down. So what do we routinely do? You have a large renal mass, Dr. Kishore. So the first question, will you always properly do a bone scan?
We do a PET scan, and we have encountered at least 3-4 cases where isolated mets in the clavicle.
Okay.
Long
so all renal cancers, you will do a PET scan?
Most of them.
Why I put this question is because sometimes, I've seen many patients where a small renal mass or a 7 centimeter renal mass, nobody does a metastatic workup. They operate.
I mean, some cases you do with mandates, yeah.
If I say so, PET CT everybody is getting, but that is not the standard protocol.
Not standard.
And many times you do a CT abdomen pelvis where you have lower cuts of the lung also. We are talking about bone, but even upper lung is missed in that. So I'm saying bone is not even touched in the preliminary investigation.
But it can happen, solitary mets.
Yeah, I fully agree with that.
Yeah. So we have gone ahead and resected it actually with the help of orthopedician. The solitary mets. We haven't had any experience giving a serotactic RT to the bone. So.
Okay. So technically, if you see a patient, sir. Initial workup, calcium and alkaline phosphate. If alkaline phosphate is raised, we would always do a bone investigation. Right, sir. Still there. But now change to PET scan. So if there is a, say, solitary or a bone oligo thing, solitary, how you manage it?
No,
because one thing I always feel is it is a multidisciplinary team discussion. Rest you answer, please.
Yes, SBRT is very straightforward, especially bone mets, spine mets, easily treatable. This abstract has shown 90% control rate, which I think is fair. It's as good as any surgical resection.
So it's a old paper. I think it's a 10-15 years old paper.
But in the article that I presented, that spine metastasis did better than other
exactly.
bone metastasis.
Kishore said
yeah, so if it is mastectomy is also a good option in that case, because it is not in the spine. And doing SBRT in a humerus spine or
okay. So coming to the last paper,
that must be the biology of the disease. They said the better outcome was with the spine metastasis, not with the spine SBRT
RT as such. So it's probably representative of the... No problem, but the article says that it's spinal metastasis, they did better with SBRT. Yes, it's the biology of the disease, not so much the SBRT
So spinal,
technique.
yeah, that is the biology of the disease, but that does not mean that SBRT cannot be done in the humerus. It would be much more simpler. We don't have a critical organ.
Agreed. I think that is a point.
And also it would be a...
Hazard was on the same side. In fact, hazard was better. Yeah, correct. A very good hazard for these patients.
Okay. So this is on the last abstract, outcomes of RT plus immunotherapy, which Vinay presented, and then we had these patients not doing well in the paper. Am I right?
Yeah, absolutely.
So this question to you, is there potential ability for RT to induce abscopal effect or not?
It was a mythical belief. It still is mythical belief. This is proof that this is absolutely a mythical belief. Those patients who received radiation have not benefited.
So you don't believe in astrology?
I don't believe in abscopal effect of radiation.
So sir, Amit Ghosh sir, if you see patient of MRCC and these options are there, we had outcome of radiation therapy plus immunotherapy. So RT to the kidney.
No, bone sites, in any radiation.
Any radiation.
Invariably it was bone mets or brain mets.
Brain mets.
And
Not to the primary.
not to the primary, sir, not to primary.
So would you prefer any kind of surgery, RT?
No, where to, sir? The question is where.
Ganesh is asking question, whatever you gave, I agree, your argument can be, it was not SBRT, so you don't have scopal effect. Some effect, negative you don't expect to see negative.
IO was given on both sides, so it should be same probably, that's what I said.
No.
Then if their poor performance status, disease burden is higher. When you are doing high fractionated radiotherapy, SBRT, disease burden is lower. So probably they could have done better. I mean, it's just an afterthought.
So this is in Canada. It is state-funded health. So they need to justify every treatment. So those patients who are really symptomatic or really needed treatment only would have got the treatment. So they are the bad biology disease. It's purely a selection bias.
So maybe. Thank you. Thank you so much.
Thanks a lot, sir. Thanks to the panel for a wonderful discussion. I think we're going to take 2 sponsored sessions now, since we are ahead of time. So Bakshi sir, if you can still stay up to deliver your talk on agonists versus antagonists. And after that, Dr. Kumar Prabhat sir for case studies in metastatic disease.
Thank you. So this is a sponsored session from about AstraZeneca, Unleashing the Controversy, LHRH agonists and LHRH antagonists. Who need rapid reduction of testosterone, which are T3B are high risk, and randomized into short-term androgen deprivation of 4 months versus only neoadjuvant versus neoadjuvant. 10. Goserelin was used as neoadjuvant in locally advanced prostate cancer. T2 to T4 M0 with or without pelvic lymph node involvement with the locally advanced group in the inclusion criteria, and randomized to neoadjuvant Goserelin plus followed by radiation and Goserelin versus radiotherapy alone. Now, it's a standard of care nowadays to offer multimodality in these kind of patients. Here the median follow-up was 6.7 years. This trial was published long back in 2008. And a 10-year survival update was performed at a median follow-up of 10.6 years. The primary analysis conducted at, as I said, median follow-up of 5.9 years. At 10 years, 23.3% versus 35.6% had died of prostate cancer in the Goserelin plus flutamide plus RT versus the RT alone arm, and 51% reduction in the risk of prostate cancer specific mortality over 10 years with the addition of Goserelin. Survival results with neoadjuvant Goserelin plus flutamide and RT versus RT alone. So at more than 10 years of follow-up, 64% versus 49% in the 10-year PFS. So if you see the forest plot, it favors radiotherapy plus Goserelin. So patients, as per this study, patients who were post-RP needing radiation therapy, there would be more benefit with adding Goserelin. Goserelin has again this going on to the metastatic prostate cancer. It has been as effective as surgical castration in the clinical outcomes. So the initial papers were surgical castration rates of testosterone. The Goserelin paper had reduced testosterone levels of less than 20. And in these publications with Kayseri et al., phase 3 randomized multicenter trial, the primary analysis was conducted at median follow-up of 63 weeks. The patients had all histologically proven metastatic prostate cancer, median follow-up of 2 years, and there was clear benefit, again a similar trial by Vogel-Zhang. So the Goserelin here everywhere was as effective as a surgical castration, which was considered the standard of care. So if you see mean time to response, it is as good. The mean duration of response is as good. Comparative data between surgical castration and medical castration, almost same with Goserelin. Large clinical trials with extensive follow-up, again, with all the 3 stages of localized prostate cancer, locally advanced and metastatic, shows good effect and benefit with using LHRH agonist Goserelin. Recommendation for ADT across disease states is quite consistent between the guidelines today. NCCN, EAU, ESMO, ASCO, all use LHRH in high-risk localized disease with radiation as neoadjuvant as well as adjuvant. In locally advanced also, ADT of 2-3 years has been used. There are papers which have reduced this duration in some high-risk localized to 18 months from the earlier 36 and 24 months. And M0 or M1 CRPC, castrate levels of testosterone are yet maintained by continuing the medical castration, or the sometimes these patients are pushed on to the surgical castration. So if you see the overview of LHRH agonists and antagonists, there are a couple of agonists, Goserelin, Leuprolin, Triptorelin, Buserelin, and Degarelix still stands across all of them. Has been used, if you which are safety concerns, injection site reactions, clots reported significantly higher ISRs in the pooled Degarelix groups, 40% versus the LHRHA groups less than 1%. These reactions were mostly mild or moderate in severity and occurred predominantly after the first injection, 33% versus maintenance dose injections where this reaction was lesser. The author suggested that the difference in ISR might be due to the different forms of administration and T-Degarelix achievement of castrate testosterone levels that enable it to be used in aggressive prostate cancer for progression. However, a wider use of Degarelix is restricted by the lack of dose that lasts more than a month and a higher frequency and severity of ISR. There are reports of Degarelix used to ensure rapid testosterone suppression without a flare, followed by a switch to a more tolerable and easy to administer LHRH agonists. The NICE guidelines also report that despite advantage of Degarelix providing more rapid and improved disease control,
and that time, so we had a whole discussion, so there is no point dwelling on it. You have a oligoprogressive disease or oligometastatic disease, and then what do we do? Here, I think so they decided that, looks like lots of surgeons there, so they decided to on. By and large, it works little, but yes, people do it, and once in a while you see those responses. These are some of the studies why we use these drugs in these different settings, highlighting, and many of them we have been discussing for almost now half the decade or more than half the decade, showing why ADT gets used and how it benefits the patient, and also the all ADT are not same, and Dr. Ganesh explained it in detail about it, and you can choose one of them, whatever you want to choose in the clinic. These are for the strength and weaknesses. So the patient progresses and then becomes them. Not a single one is left there, by and large, those oral tablets or injections. Cabazitaxel, because it failed, so it got out, so it has remained in CRPC. My feeling is lutetium, by and large, in a year or 2 or 3, it is going to be an HSPC. So always the question remains, how do you use the sequencing? And that's why I keep saying, whole lot of our practice is not on level 1 evidence. We say, no one is going to do this study again. You will be kept using this drug, which is sequentially, because the data is indirectly being there, so we'll use one of them. And these are data for abiraterone and cabazitaxel together. And there is a decent data for platinum in, iska naam kya hai, BRCA positive. So not a bad idea. We do this routinely, and you are aware of it. But to say that, yeah, someone needs to work on it. This is one area where you can, it looks fair. Others, it doesn't look fair. As much, I agree with you, and good you asked this question. So as much we say HRR, HRR has a connotation. So there is a concern regarding others, and not only here, it is a concern regarding in multiple places. So non-BRCA, be careful. Non-BRCA, non-ATM, be very careful, in that setting. Yes, sir. And combination, not sure what that combination does, but we are. So, but Abby looks like, because they are exposed to Anza or something, they have to, for the trial sake, they have to made it, and they had some reasoning also. Morning, Vamsi was talking about why the reasoning was, but my feeling is that looks like pattern of outcome remains same, if single agent also. So I'm okay with it, but I won't mind combining. If I have to stop it, I'll stop, abiraterone.
So quick comment about your question. If it is first line, then the preference will be towards combination. In first line CR patients, the preference will be for combination. But subsequent line, we have the data of only single agent. We don't have the data for combination. So far as HRR genes.
Many of the patients were exposed to the novel anti-hormone.
Yeah, but they were
in
not,
the PROPEL, they were exposed to novel
anti-hormone. They were not on abiraterone in last 4 months.
They were not. Yes, there was a gap of 1 year.
Yeah.
Yes.
So, so far as HRR is concerned, my understanding is that it's a dynamic inclusion of 15 different genes. It's dynamic. In the coming years, some of them will go away, some new will come in. So let us see what comes out in next few years.
Yeah, there is a registry there. I think there's a very nice registry by some group they have made, and they are putting all these patients, and what they want to do, each mutation, each gene wise they want to come up with, does the drug works or not. Looks like that is the way we may get the answer. But no doubt that curve doesn't look good. At the moment you go beyond ATM, the curve doesn't look good. If none, then thank you. Thank you so much. Thank you so much.
Okay.
of trials. For the first one, I invite Dr. Ajay Singh to talk about his on the efficacy and safety of some drug combinations for renal cell carcinoma with a high risk of recurrence.
Thank you, sir. So good evening, everyone, and thanks to the organizing team and Randeep sir for giving the opportunity. So basically, I'll be discussing regarding the role of adjuvant therapies that is beyond TK immunotherapy in advanced resectable RCCs. So as we know why there is a need for adjuvant therapy, because almost 1/3 of the patients present in curative stage, and among the patients who get resectable surgeries, again 30-40% patient had relapse, and overall the 5-year survival rate in these patients who develop metastatic disease is around 10%. So definitely there is a need to add some additional therapy in addition to curative therapies. And among these, the patients who undergo surgery, there are multiple risk scores to define who are the low risk group, who are the moderate risk group, and high risk group. And commonly we generally use UISS classification risk scoring based on the TNM and performance status and the grading score. And in this group, you can see that the patients who are having a low risk, almost having a median OS of around 30 months, then intermediate risk having a median OS of around 18 months, then high risk group having a survival less than a year. So almost 9-10% in the low risk, 40% in the intermediate, and 60% patient in the high risk group have a relapse of the disease after this curative surgery, and their survival is in at least high risk, they're not even a year. So this is a summary of adjuvant TKI in patients who underwent surgery, and out of this only the S-track was the positive trial. And in S-track you can see that the patients who had a T3 high grade tumor or T4 with or N1 disease has shown a significant benefit along with patient having a grading tumor grade of 3 or 4. So, and in this the only benefit was seen in terms of the DFS. There was no any survival benefit. So based on this trial, so sunitinib is somewhat got recommendation in US countries, and it is a NCCN category 3 recommendation to patients who are having these high risk features to recommend sunitinib as an adjuvant drug as for 2 years. So as we know, high risk features. So they included a T2 tumor with grade 4, T3A, grade 3 and 4, then T3B or C or T4, or any node positive disease, or patients who had limited metastatic and underwent R0 resection, and included clear cell and sarcomatoid variant. So they randomized this patient atezolizumab for 1 year against placebo, and with key primary endpoint of DFS in intensive to treat from population, along with the overall survival in intensive to treat population and DFS and safety profile. So baseline characteristic was almost similar in both the groups, and you can see that there was some PD-L1 positive patients, almost around 60% patients had a PD-L1 positivity. So the initial results was not favorable, and both DFS and OS was not significant in intention to treat population. And in the subgroup analysis, you can see that in patients who had some sarcomatoid variant or the PD-L1 which was higher side, that is more than 5%, they have shown some benefit. So based on this PD-L1 positivity in patients who has more than 5% of PD-L1 IC score or 2 or 3, they have shown some benefit. Otherwise, overall this was a negative trial. There was no any benefit. So for this trial, the conclusion was adding atezolizumab will not be help in prolonging any outcome, and only in subgroup they have suggested, that is sarcomatoid variant or high PD-L1 expression, there may be some benefit. So again, the next trial was the Checkmate 914 trial. So it was a adjuvant nivolumab plus ipilimumab, and the major change is that duration of therapy was around 6 months in adjuvant setting. And again, almost they have included similar high risk patients with the P2A, including grade 3, 4, then P4 and PT tumor and any node positive tumor. And here they randomized patients for initial 4 cycles of Nivo-IP combination, and followed by continuing Nivo for at least 6 months. And the immunotherapy era also, except for pembrolizumab, the other 2 trials
of angiogenesis has been linked to enhanced efficacy of immune-based cancer therapies. And increased PD-L1 expression has been associated with shorter survival in clear cell RCC who are treated with VEGF inhibitors like pazopanib or sunitinib. So the rationale is to combine the VEGF pathway inhibition and subsequent follow-up. So this is a 3-year data cutoff, and after a median follow-up of 44 months. So it also includes the subgroup analysis by IMDC risk category, and it was 16.6, and in the sunitinib it was 8.4 with an impressive hazard ratio of 0.58. It also translated into the overall survival, in which the OS was 49.5 months in the Nivo with cabozantinib, and versus 30.5 in the sunitinib arm. That means we had a 14 months of OS advantage and nearly 8 months of PFS advantage. 8.4, and hazard ratio was 0.59. So overall, also we had a 14 months of OS advantage with a combination of Nivo with cabozantinib versus sunitinib. So this is the OS data. We can see that in the patients who have favorable risk, the curves are nearly overlapping, whereas in the intermediate risk, it is separating wide, and definitely in the poor risk, we can see that the Nivo plus cabozantinib is it is favoring the treatment over sunitinib in the poorest especially, although it is there persistent across all the 3 subgroups. So moving on to the response rate, the overall response rate of the combination arm was 55%, and the sunitinib was 28.4. The CR and PR, both the CR, PR and both the things, they favor the combination arm of Nivo and Caboza versus sunitinib. And we can see that 6.2% patients had progression in the combination arm and 13.7% progression in the sunitinib arm. The median duration of response was also high in the combination arm, which was 23.1 versus 15.2 months in the sunitinib arm. So here if we subclassify according to the IMDC risk group, here also across all the subgroups favorable, intermediate and poor risk, we can see that the combination arm fared better as compared to the sunitinib alone. So moving on to the adverse effects and the toxicity profile, we can see that the common toxicities which we see in our clinics is like the diarrhea and hand and foot syndrome, which was also reflected in this trial. And we can see that the any grade toxicity was seen in 97%, and the diarrhea was a predominant side effect of the combination arm, which was seen in 55 of any grade, and the grade 3 was seen in 7%. In comparison with sunitinib, it was 46, and any grade was 5. The other side effects are hand and foot syndrome, hypertension, and fatigue and hypothyroidism. But the grade 3 adverse effects which predominantly are our concerns are hypertension, diarrhea, and hand and foot syndrome. Definitely there is some the others the toxicity profile which we look are the mucositis, stomatitis, anemia, thrombocytopenia, and transaminitis, which was slightly higher in the combination arm, but the anemia was higher in the sunitinib arm. So if we talk about the treatment exposure and subsequent therapies, we can see that the median duration of treatment of Nivo plus Caboza was 21.8, and sunitinib it was 8.9%. The dose reduction was seen in 62.8% of patients in the combination arm versus 54% in the sunitinib alone. Disease subgroups, the use of subsequent therapies after discontinuation was also higher with sunitinib versus nivolumab plus cabozantinib, and the results they continue to support the combination of nivolumab along with cabozantinib as the first line treatment options for advanced or metastatic RCC. So the takeaway from my end is like the sustained OSS 3 years follow-up. The median duration of response was 22.1 months. There is a ORR data. The time to subsequent therapy is also impressive, 20.6 months. There is a depth of response. There were a large number of patients who were poor risk patients. Nearly 19% of the patients in this trial were poor risk patients. The one variant which we are concerned is sarcomatous variant. In sarcomatous variant also the PFS was 13.8 months and OS was 37.5 months. With this I would like to end this. Thank you so much for attention.
Thank you very much. Can I ask for the next speaker, please? Shantanu Pense.
Good evening all. My today's topic is, thank you first for the opportunity given. Today's topic is phase 3 trial of addition of cabozantinib to doublet immune checkpoint inhibitors, nivolumab and ipilimumab, Cosmic 313, which was, so the background for this trial is formed by 3 trials, that is Checkmate 214, which was phase 3 combination immune checkpoint inhibitors trial compared to sunitinib, which showed OS and PFS benefit. Overall response rate as well as duration response was better with doublet. No additional safety or toxicity issue was observed, but the treatment discontinuation rates was high and use of high dose glucocorticoids was high, suggesting that higher clinically significant toxicities were more with combination of immune checkpoint inhibitors. Then cabozantinib trials came, and then Checkmate 9ER, which Dr. Darshit recently presented, update show is also weekly, plus minus cabozantinib or placebo. Cabozantinib dose was 40 mg per oral per day, and the nivolumab treatment duration was a maximum up to 2 years. This is the 1:1 randomization design. One prior adjuvant systemic therapy was allowed for completely resected RCCs, and pardon this mistake, if recurrence occurred after 26 weeks after the last dose of adjuvant, the treatment of inclusion was allowed. Tumor assessment was done initially at week 10, then every 8 weeks through up to week 50, that is up to 1 year, and then every 3 months thereafter. And discontinuation of one agent did not mandate discontinuation of all agents. Baseline characteristics were almost similar. Median age was 60. Baseline was also stratified for PD-L1 status, intermediate and poor risk stratification, prior nephrectomy status, common metastatic sites, and primary endpoint was PFS for first initial 550 patients. It was blinded independent central review. Secondary endpoint was OS, which is yet to be presented officially, and additional endpoints were overall response rate, duration of response, and safety for all randomized patients, that is intent to treat population. Median follow-up for intent to treat was nearly 1.5 years, and duration of trial was from June 2019 up to March 2021, consisted of total 855 patients, of which 3/4 of the patients, that is 75% patients, were intermediate risk, 25% were high risk, and 428, almost similar number in both the arms, received cabozantinib and placebo. What were the results? This trial was positive for its primary endpoint, that is PFS. Addition of cabozantinib to dual checkpoint significantly improved PFS with hazard ratio of 0.73, which looks impressive, though median PFS is not reached, and median PFS for placebo arm was 11.3 months. And the benefit was found across all the subgroups, including age, sex, geographical variants, including sarcomatoid histology and PD-L1 status. As we can see in this Kaplan-Meier, a separation starts at about 3 months, and the gap is maintained up to the follow-up of nearly 2.5 years. There is consistent difference in the graphs. What was striking is there was little more benefit of addition of cabozantinib to intermediate risk group than poor risk group. A reason is unknown. Maybe IMDC subgrouping is not yet, may not be valid, and it is 3 patients with grade 5, that is death as adverse events. Probably it was immune-related and immune-related hepatitis. One death was immune-related hepatitis and one is myocarditis. 2 of the deaths were within 30 days of the last treatment duration, and one was after 100 days of the treatment. So these are the common side effects: AST, ALT elevation, diarrhea, expected on the line of cabozantinib. For cabozantinib, immune-related fatigue and lipase amylase elevation. Median response, treatment exposure and duration, number of treatments received is relatively lesser in the cabozantinib, nivolumab, ipilimumab arm. So fallout is higher in the triplet arm, probably related to toxicity. Dose holding is also significantly higher in triplet arm. So investigators' conclusion was improved PFS for cabo arm for previously untreated intermediate and poor risk across all subgroups with greater benefit in interim group with numerically higher overall response and disease control rate with manageable safety profiles consistent with individual profiles of given agents. And ongoing follow-up is going on for OS. So does it change current standard of care for me? Probably no. Till OS data is mature, it is difficult to say that this changes the current treatment paradigm. In addition to that, there are significant toxicity, including financial toxicities and increased hospital visits. There are no... another question is whether... one more question is whether cabozantinib addition to nivo is better than... triplet is better than cabo plus single agent nivolumab, that is single immune checkpoint inhibitor. That needs to be answered. So probably this trial is not going to change current standard of care in upfront RCC till longer results are available. Thank you so much.
Thank you very much. Thank you very much. Can we have the next speaker, please? Ashish Joshi.
So good evening, everyone. Thank you, Randeep. Thank you, organizers, for giving me this opportunity. Disparate from what my previous colleagues have spoken, this is more of an observational study, but it focused on a so-called orphan disease. It's a non-clear cell metastatic renal cell carcinoma. And as we all know that it constitutes almost 25% of the metastatic RCC that we see in the clinical practice and also is backed by the literature. The issue with this is that there are most of the pivotal trials which includes RCC would exclude non-clear cell histology, and hence there is no optimal standard of care. And if you dwell into the clinical or rather the algorithms, it's still mentioned that type 2 depending on the MET and the RET oncogen overexpression. The non-clear cell ones, the metastatic RCC, whatever the evidence which we have is very limited evidence, with most of the numbers of the trials includes 30-40 patients. The current standard of care includes data for nivolumab plus cabozantinib. There is a phase 2 study which is showing the overall response rates and disease control rates to the tune of 50 to 70%. There is a study of lenvatinib plus everolimus which works across all the non-clear cell subtypes and again gives a disease control rates of 50 to 70%. Axitinib monotherapy, there is some evidence of disease control rate, and there is also evidence that pembrolizumab monotherapy is active, but the response rates of monotherapy metastatic RCCs. So metastatic RCC, non-clear cell carcinomas constitutes almost 25% of the patients with RCC, very limited therapeutic options, and they have generally overall lower response rates compared with metastatic clear cell RCC. So this study aims to investigate the effectiveness and tolerability of pembrolizumab plus axitinib combination as a first line in chromophobe and papillary metastatic RCC. This study actually included only patients with chromophobe and papillary RCC, which constitutes almost more than 80% of non-clear cell histology, but there were 2 or 3 patients with sarcomatoid, not variant, sarcomatoid features, non-clear cell RCC as well. So the baseline characteristic, overall response rate, disease control rates, and the PFS and toxicity were retrospectively collected from 12 Italian referral centers from December 2020 to April 2023, and only patients with chromophobe and papillary histologies in this particular observational study. So these were the baseline patient characteristics. As you could see here, chromophobe and papillary are the ones which are predominant. There were patients who had IMDC score of good, intermediate, and poor risk. Predominantly intermediate risk is what were included. Many of the patients had previous nephrectomy, or also some of them underwent cytoreductive nephrectomy, had a decent performance status for all 3, and they had synchronous metastatic disease involving bone, liver, lung, and nodal disease. So these were the radiological response rate that you could see. CR rates were seen in none. You had a partial response of almost 43% in the overall population, and 16.1% in the chromophobe and 19.3% in the papillary histology. There was overall response rates of 43.7% at a group level, but at an individual level, the chromophobe 1 had 41.6% and 47.3%. And I think that probably allude to most of the previous data that we know, that the chromophobe are not the one which respond very well to the treatment compared with the papillary histology. So overall response rate by the histology, again amplifying in this particular bar chart, were 47.3% in the papillary subgroup and 41.6% in the chromophobe subgroup. Again, similar to what has been echoed in the previous phase 2 study which I just mentioned before. And the disease control rate, which includes partial response as well as stable disease, was hovering around 60 to 70% in the papillary histology and around closer to that in chromophobe histology as well. So the regimen was active in both chromophobe as well as papillary variant of the non-clear RCC, and fairly decent response rates and disease control rates. Again, this study is not powered to study PFS and OS, but the progression-free survival is around 10.8 months, and which is what actually you see in most of the non-clear cell RCC studies, except for the monotherapy with pembrolizumab and axitinib, where the PFS was almost 6 to 7 months. So this again is consistent with the observation that we had with the previous study, that the PFS was around 10.8 months. Median progression-free survival in the papillary variant again was 10.8 months. So the results were 25 to 30 eligible patients, fairly impressive disease control rates of 70 to 80% in both the subgroups, slightly inferior in the chromophobe versus papillary, and the partial response rates or the overall response rates of close to 50% in both the histologies. Again, the tolerance was fairly okay. 34.3% had to interrupt the treatment because of the immune-related adverse events. Grade 3 hepatitis, grade 3 hypophysitis, grade 3 diarrhea, grade 3 pancreatitis and asthenia were seen, and 12 patients interrupted temporarily because of axitinib due to persistent hand-foot syndrome and hypertension. So the conclusion of the study is that pembrolizumab axitinib combination could be an active and feasible first-line treatment options for patients with papillary or chromophobe RCC. And my comments would be that data is too small, but all metastatic non-clear cell RCC data is around for 30 patients. So maybe we could debate on that. It's again an observational study. We have a data of nivolumab cabozantinib phase 2 data has a similar disease control rate and overall response rates. The keynote 427 data, which is pembrolizumab monotherapy, overall response rates was, as a monotherapy, was inferior with a PFS was just 4.8 months vis-a-vis 10.8 months, as you could see in this observational study. And probably it's the way of, can we declassify this
both for the surgeons and medical oncologists. So this was an abstract which talked about the grossing and reporting of post-immunotherapy nephrectomy specimens. So this is not a common thing. This is from a single institution, the MD Anderson Institute, and some of the pathologists on board are my good friends in this. Single institution experience of 70 cases. So immunotherapy is being increasingly used as neoadjuvant chemotherapy. We all know that, and in management of advanced RCCs, somewhere in the renal sinus fat, somewhere in the perinephric fat, you might find some viable tumor, and that's important. So what was the result? That they found discrepancy between the macroscopic and the microscopic extent of the tumor, and the post-immunotherapy staging may not be exactly translated from the AGCC staging which you use for a radical nephrectomy specimen. So post-immunotherapy staging might be different, and it has to be looked up into, and that's one of the important results of this study. Another important finding, they divided these tumors into two groups, group A and group B, based on the viable tumor post-immunotherapy. So the patients who had less than 20% viable tumor post-immunotherapy did very well compared to the group B, which show more than 20% viable tumor. And that's why you need to grid the tumor and take multiple sections so that you exactly know what is the amount of viable tumor. And this is the curve which they have charted out, which can clearly shows that the tumors which had more than 20% viable tumor post-immunotherapy radical nephrectomy, they have done worse compared. So this is an important thing. So these are a couple of papers from PubMed which I picked up, which have now studied, lot of studies are coming on neoadjuvant nivolumab and other immune checkpoint inhibitors before you do a cytoreductive nephrectomy in these patients. So I think this is something which is going to come in the future more and more. And this is a big study from a very, very important institute, the MD Anderson study. So the basic conclusion is that we have to grid the tumor because the microscopy and the macroscopy would be different. The staging might be different post-immunotherapy. and the importance of the amount of necrosis post-immunotherapy is important. A couple of discussion points which I put here maybe can be discussed in this panel is how common is it in India to do resection post-ICA for the surgeons, how easy, difficult. Aman is here, maybe I can put this question to him later. And is this a paper cue on how to evaluate the response, and is there any radiological or other tips on radiology how to pick up the response? So that's the first paper. The second paper is again a little relevant in the day-to-day practice. Strangely in India, we have a lot of prostate cancer patients who come early. We have many patients who are less than 50. In TMH, we conducted a recent study in which we have picked about 50-55 below 45 prostate cancer patients. So are there some histological features which suggest that you can do this HRR testing in these prostate cancer patients? This was a study again from Salt Lake Utah University. So this is the background. We know that somatic and germline homologous HRD, HRR mutations are seen in up to 20% of prostate cancer patients, and they are now known to respond to PARP inhibitors. And this study, they hypothesized that the histological patterns might be helpful in saying which patient should go for HRA testing. We have some guidelines, the NCCN has some guidelines. There is a Philadelphia consensus guidelines of 2019 which spoke of this, but I don't think in day-to-day practice we refer to it in prescribing this kind of test. So what they did in their design is they took 130 patients with 38 BRCA1-2 positive patients, 36 with non-BRCA1-2 HRD mutations, and 56 as a control group which did not have any mutations. They were evaluated by histopathologists to see if the histopathology correlated with this BRCA mutations. The results were a negative study. So the NCCN as well as the Philadelphia says that if you see cribriform pattern, intraductal pattern, you may suggest that these patients are likely to be BRCA mutated. Strangely, they have found that neuroendocrine carcinoma, when it comes, they are likely to be BRCA mutated. So there is a case that neuroendocrine carcinoma small cell of the prostate may have a BRCA mutation, and those should be tested. And again, they are bad tumors, and they may be a case for BRCA PARP inhibitors. So this is a table. I will not go into the details of this. We can discuss it out during the panel discussions. And the conclusions and take-home messages are that histopathological patterns, even though there are guidelines which say that they can be predictive of HRD, this study did not find that a marginal increase in neuroendocrine morphology and a high volume cribriform pattern was seen in BRCA1-2 mutation. And so the importance is that you have to decide on a day-to-day basis which patients to send for ancillary molecular diagnosis. Most of them are young patients with a family history, and those are the patients who would be harboring these mutations. Again, the discussion points I would leave is, in your practice, what triggers BRCA testing? Do patients now regularly request for genetic and molecular testing? And do clinicians really in day-to-day practice, maybe we can discuss during the panel, follow the Philadelphia consensus guidelines or the BRCA testing? And as a Eurocare team, I think when you do a genetic testing, you have to have a genetic counselor in place before you actually do this. Thank you very much.
Thank you very much. Yeah, I guess that finishes all the 5 papers. And now I think we're going to go on to the panel discussion. But before that, I'll just say these were excellent papers, went very nicely, neatly, in a progressive manner, looking first at the combination of atezo and nivo and EP, and then non-contribution, and the fact that the cabozantinib and nivo is definitely a great contributor. The third paper was again on triple therapy with cabo, nivo and EP, and in clear cell. The next paper was on non-clear cell and the use of pembro in non-clear cell. And finally, a lovely paper on the histology and the correlation and young people with prostate cancers and the need to do BRCA testing and other genetic testings in these patients. I now invite Dr. Randeep Singh to do the panel discussion.
Thank you, chairpersons, and I have two small announcements before we start the panel discussion. There is, on the behalf of Dr. Kumar Prabhash sir, he is conducting a survey of management patterns on urinary bladder cancer in India. There will be a team who will circulate among your tables, and if you have not filled up that, there is a request to fill up that survey. It's hardly 5 minutes long survey to be filled. Second, I would like to invite Dr. Amit Ghosh, sir. Sir is President of Urological Society of India Oncological Chapter. He has a small announcement to make before we start the panel discussion.
I'm actually the chairman of the Uro-Oncology section of the USI, newly formed and born on the 2nd of February during the UCCon. And it has been a universal decision that we are going to hold the annual conference in the middle of the year. All the sections, the Uro-Oncology section is hosting the meeting on the 9th and 10th of June this year in Delhi. Now, if you have not received, this message contains the registration mode as well. My appeal to all members, this is a very big conference of great significance for uro-oncology. If you can please cooperate and take some time out to register for the conference and give it a boost. It will be great for the future of the section. Thank you very much.
Moving towards the panel discussion moderated by Dr. Randeep Singh, I will invite the panelists, Dr. Ashish Joshi, Dr. Shantanu Pense, Dr. Amandeep Arora, and Dr. Deepak from Indore.
Dr. Deepak is not there. Okay, so we can have the Ajay. Ajay, can I request you to join the panel? Ajay Singh. Okay, fine. So we will have a short panel and we can invite the comments from the house. So there are 5 abstracts and apologies, the abstracts of pathology are not there, but I have noted the comments from Dr. Santosh and I will definitely include that in discussion. We will first start with the adjuvant therapy. There were 2 abstracts of adjuvant and that makes us about total 4 studies, phase 3 randomized of adjuvant in RCC. Apart from that, there is an evolution now. Just a second, I'll just put this off. There is evolution in the metastatic RCC settings and there is an escalation from doublet to triplet. And in the last, we have non-clear cell RCC, which was discussed by Ashish. And so to my mind, the ideal adjuvant therapy, and this applies to any oncological setting as well as in RCC, shall eradicate micro
patients also. We have something called as a Leibovitz score that is available, which has all histopathological features that we enter, and we get a 5-year and 10-year progression-free survival and cancer-specific survival, which I then inform the patients.
Perfect. So Amandeep, you do it for risk stratification.
Yeah.
We ask our medical oncology colleagues, do you do it for a risk stratification, prognostication, or do you do for predictive also?
So currently it's for prognostic stratification, but I think probably now that we will discuss about the adjuvant data, some of these factors will have a role to play in predicting a response to the, or whether aligning the adjuvant treatment.
So Ashish, I was just going through this UISS and of course these were also there in the inclusion criteria. T2 grade 1, how many of us are comfortable in putting, I mean, of course there are T2 grade 2 grade, but T2 grade 1, how many of us are comfortable in putting it in intermediate and high? Aman, first Ashish and then Amandeep. And then of course.
So I think if you look at the grade 1, that the biology is very, very indolent. So putting such patients into intermediate could be...
Intermediate high.
Intermediate
high. Yes, it's intermediate high. It is not even intermediate. I would have been happy. It's intermediate high, and that goes into the why I'm asking you this particular is because you know that it goes into the trials which we are discussing now.
Correct. So not very comfortable.
Amandeep?
Yeah, not at all comfortable.
Shantanu, if I'm right. Shantanu, no. And okay, fine. And what about these? This I will first ask our medical oncologist. Do we risk stratify? Of course, these are the prognostic established risk groups. The Leibovitz as well as the UISS. What about what we have learned from the clinic? And
is not a great biomarker.
Not a great biomarker. Okay. Now we come to the both medical oncologists. In today's era, do we consider adjuvant TKI? See, so before you make the comments, I will make 2 comments. If we are a hardcore fan of regulatory authorities, then only 2 things are approved as of 2023 sitting here. One is adjuvant sunitinib. Whatever we may debate the data, and one is adjuvant pembrolizumab. These are only two approvals in front of us if you want to play medico-legally safe. So what if the patient is affordable? Will you still consider adjuvant TKI? And if yes, what? Ashish and then Shantanu.
So the length and the breadth of the data with TKI is far more bigger than pembrolizumab. So I would consider adjuvant therapy in M1 NED as we speak.
Okay, interesting.
Definitely I will do it. Now whether I'll use TKI or pembrolizumab, that's something is very much debatable. The pembrolizumab data looks impressive. Probably one may shift from TKI to IO.
Okay, and if there is affordability issues or whatever, if there are contraindications for IO, such as patient had some transplant or is having an active SLE, a systemic SLE or an active autoimmune disease going on, then
M1 NED definitely sunitinib.
Sunitinib. And among these, there is an Everest trial which is not there on this slide. That was for adjuvant everolimus.
Yes, everolimus. Yes.
That was also there. So Shantanu, your comments, if you have to use adjuvant TKI in one who is financially and medically eligible for IO versus one who is not eligible for IO either financially or medically.
Sir, only for M1 NED I may consider sunitinib, but otherwise even for sarcomatoid and affording,
It's a doable regimen. Okay. Adjuvant pembrolizumab, to be very honest, I haven't used in my clinical practice.
Great. Okay, fine. That is the next question. Yes,
do all M1 NED have to go on adjuvant therapy?
Okay. Would anyone in the panel would like to take that, or all NED would like to go for that, and I will come to that comment. Yes, we can have the anyone. Okay, Chirag sir. Would all M1 NED would like to go for? Can you be more specific? Would all M1 NED like to go for adjuvant sunitinib or adjuvant pembrolizumab? You sir will answer. Very good, sir. Sir, please answer both of them for us.
My strong preference is towards pembrolizumab.
Okay.
Sunitinib, I don't think abstract included the patient with M1 NED.
No, it did not include. And I think what Ashish and they wanted to say, and I did not comment, was an extrapolation because that is a group which gets benefited.
So, till the data of pembrolizumab came in, my answer to M1 NED going for sunitinib was no. I am not using sunitinib for M1 NED.
But now, sir, today?
Today only.
No, so M1 NED not eligible for IO, either medically or financially?
I don't give.
No, nothing. Okay, fine. And all M1 NEDs will go for adjuvant pembrolizumab? That is the next question Amandeep is asking.
I will prefer.
But all financially and medically eligible patients?
All, yeah.
Okay, fine. So we will come to that point again. So again, back to both of them. Will you consider adjuvant IO? There are 4 trials now. The Keynote 564 we all know, that is of adjuvant pembrolizumab for a year. IM Motion 010 as well as Checkmate 914 were presented, and one which was not presented is Prosper. Prosper was one dose of one dose of new adjuvant Nivo followed by 9 months of nivolumab post-op. Only one dose was given before. They have different inclusions criteria, but one thing is common among all these. All of them have at least high risk. Intermediate may be a debatable thing, but high risk they all of them have, and 2 of them have M1 NED, Keynote 564 as well as IM Motion 010, and most of them have a sarcomatoid. Even Prosper had M1 NED, and we will look upon that data. So with this, again Ashish and then Shantanu, will you consider adjuvant IO? If yes or no? And we have the data, and you know that there is only 1 positive, 3 negative standing against. And before you make a comment, these are the graphs. The first graph on the right hand upper is adjuvant pembrolizumab, and I am happy that there is some tail happening, and the tail which all oncologists look in IO trials, the tail is getting achieved here, and that tail is maintained, which gives you some confidence at 30 months of follow-up. IM Motion 10010 adjuvant atezolizumab, no tails. Checkmate 914 absolutely negative till 48 months, and Prosper again till 36 months or even beyond. There is hardly any separation. So with these 3 standing against 1, Ashish, what will you?
So it's 3 versus 1. I'll always go for the majority.
Now it has become 3 versus 1. First it was 1:1.
But again, going back to that previous discussion about the prognostication models, correct? And the risk stratification that we've discussed. So have we optimized them adequately? Does it include all the qualitative as well as the quantitative factors which are required for a risk stratification? I think that's something which is very, very important and still debatable. There is still one only trial which is showing DFS benefit, 3 are negative trial, So if you ask me honestly today, I would probably not do adjuvant IO.
Pembrolizumab.
No.
Okay, Shantanu, your comments.
Sir, I would
And I
still-
will come to subsets. Let us have a broad, Ashish, what a broad one, then we dissect out the subsets, of course, because the data is the intention to treat DFS.
I would still be tempted to use adjuvant pembrolizumab in at least M1 NED and sarcomatoid histology.
Okay, so now we will focus on these two subsets, M1, NED and O. So I will present the data of all the 4 trials. The first one is adjuvant pembrolizumab. Of course, M1, NED, total number of patients are 50 out of a 700 database trial. As in sarcomatoid, if you see on the pembro, of course, there was a benefit with a hazard ratio of 0.54. The other true, there is the sarcomatoid, again the benefit is in adjuvant nivo EP. The hazard ratio is similar to adjuvant pembrolizumab trial of 0.3. But in perioperative nivo, when one dose of nivo is given, only one dose nivo, and it is mainly a post-operative nivo only. Again, if you see sarcomatoid is not there here, but there is a M1 here, but in M1 again you can see the diamond you can't see because that is on that line of unity. And there is a wide confidence interval, and the most part of the confidence interval is against using the IO. Now you tell me, that is an old age concept that these tumors will regress on their own once that the parent is removed, and that is what was taught from us, not now, from 10 years, that RCC is a tumor when you remove the parent tumor, and then these micrometastases may disappear. And we have seen initially, I mean, I have seen in my practice at least 3 patients who had these small lung mets, 1 or 2 or 3, and they were just kept on observation, and they remained on observation after their cytoreductive nephrectomy was done. And that is why it always makes me think that whether we are helping them or not. Shantanu, now M1 NED and sarcomatoid. I don't know. That is why we are discussing. If you know the answer, I would have told you directly that yes, do this. We don't know. That's why we conduct these points in the discussions and discuss here in the meeting.
Sarcomatoid, I would like to discuss it at least with the concerned patient, even for DFS benefit.
And then M1 NED, your confidence is shaken.
M1 NED, yes.
Now the confidence is shaken. Chirag sir, can you help us? And anyone else from the floor? Sir, after this data, you can guide us as what to do.
So in the morning, the same discussion happened, and I said that we should treat the patient with adjuvant therapy where it is likely to work the best, not in the very early subset, not in the very advanced stage where it's not going to work. So Ganesh, I think Ganesh had given the example of the thrombus reaching up to the intrahepatic.
Sir is there right behind, yes. Ganesh sir is there, yes. So intrahepatic, same question, intrahepatic IVC involved or nodes positive, but R0 resection done.
And maybe 3-4 lung metastasis excised totally. That is very advanced disease, and that disease is going to come back whether you treat now or not. But if a 6 centimeter tumor and one lung metastasis is totally excised, so these are the patients who are likely to be benefited the most. So this is the patient whom I will treat. The other patient I will not.
So, but M1 NED by definition is that all the synchronous and metachronous metastases are resected, whether there were 1, 2, 3, 4 lung or it does not, or even a bone, it does not matter. The definition in all these trials have been that there is no evidence of disease and the metastatectomy has been done.
I will use my discretion.
So is there any M1 NED whom you would put on surveillance? Any M1 NED?
I think same question what Amandeep was asking before now.
Is there any patient that you can say, ha, ye patient ko I will put on surveillance?
For very advanced disease, whom I think that by the time patient will be discharged, patient will come with some.
So, but then there are more so reasons, sir, to start them on a therapy. If you know that they are going to relapse on the first follow-up, then there are more so reasons to start them now.
The point which I want to make drive is that there are some patients who are very advanced, who are going to have the recurrence. In those patients, I will wait till the recurrence occurs. So there are some patients who are going to be cured without any adjuvant therapy. There are some patients who will not be cured in spite of adjuvant therapy. We don't know who are they. We don't know at present who are they. But applying the common sense, applying the logic that we are applying in day-to-day clinic, I will use my discretion.
And then you will have to stop the therapy at 1 year in these patients.
Yeah.
And also, I think, completely agree with Chirag sir there, and hence probably sunitinib is the middle way.
I think sunitinib will be very difficult to justify because, I mean, either if you have to give it, you give it a adjuvant pembro, else you don't give anything. I think that is my take. And toxicity, there is actually, and that was actually comment by Amandeep only, that is that this is a slide grade 3-4. I will just concentrate on clinically significant toxicities. Atezo is 27%. The right hand curve is the Pembro keynote trial. I'm very bad with numbers, but the grade 3, 4, 5 is 32%. Discontinuation, and again the Nivo EP, it is around the grade 3, 4 is 38%. Treatment discontinuation in Nivo EP adjuvant is 32%. And in the Pembro is 10%, and in Atezo single agent treatment discontinuation is last one 11%. So it's 10 to 30% treatment discontinuation as you intensify. And of course you are giving toxicity. It is not a easy regimen in the adjuvant setting as well as others, but these are grade 3, 4. I'm not talking about 1, 2 toxicities here. So to summarize, and we can have comment from all three, starting from Shantanu. Are you satisfied with the trial designs? Both the trial designs were placebo-based. All of them are placebo-based. Yes.
Nivo EP looks like over-treatment with given toxicity. Shorter treatment duration is also different. I mean, it is intense and shorter duration, which is probably not justified.
But you don't feel that these trials should have been compared with sunitinib when you have only one approval, and the trials, the ones they had started, why they were not compared with adjuvant sunitinib? We all discussed that we will give adjuvant sunitinib, and if these data would not have been there, either you observe them or there is an option of sunitinib. So are you satisfied with the trial design? That is the question.
Probably sunitinib also with an adjuvant setting has a lot of weaker data. Probably
so trial design is satisfactory.
So trial design is okay.
Fine.
But again, 2 drug for an adjuvant setting, I agree with Dr. Shantanu.
To give or not to give, that also you tell. Practice changing to give adjuvant or not to give adjuvant?
Give adjuvant after discussion with due discussion.
So you will still consider.
Patients, yes.
Okay, and it can be adapted if finances are met. Amandeep, any separate comment? And OS are almost similar. If you see 0.7 is the hazard ratio. Why the Checkmate 9ER and clear trials are showing a very good hazard ratio? Don't get carried away. Their follow-ups are very less. They're just 23, 24 months. So that is not, but OS, all of them are hovering around 0.66, which is a clinically and a medically significant. There are other differences, of course, that the combinations of Nivo, Cabo, Pembrol, and Vertinib are more active. And there is a difference of, shows you very good results, had only 9% poor risk, which is the least. And to my mind, Nivo Cabo appears to be best. It has 20% poor risk. And in spite of that, they have done well. And we have a follow-up data, which was presented by the speakers, and they have the PFS is holding to 0.73. Chirag sir, your comment, and then we come.
So my question is to any of the panelists about favorable risk.
Okay.
The recommendation you said that all three combos are preferred.
Okay, sir, I will include that. Please give me time. I will include that. So where do you place update Checkmate 9ER, and then there is a Cosmic data. Cosmic data was, so let us start with Checkmate 9ER, and this was the slide, sir, where the hazard ratio for the favorable is also put. So let's talk, where do you place Checkmate 9ER? Follow-up data of 44 months, which is a good enough. And then there is a triplet also here, which is a Cosmic. Before you make comments, I will just summarize this slide. Cosmic, one good thing I liked about Cosmic is a very early separation of curves starting at 3 months. The tail is maintained, but 35% of the patients did not underwent nephrectomy. And when we talk about ipilimumab, this was not brought up by the previous speakers, percentage of patients who were receiving 4 doses of ipilimumab is 58%. And yes, there is a hazard ratio of 0.73, which was statistically significant for the intention to treat. So where do you place them with this data set? We can start with Shantanu and then Ashish. And then, of course, the comment was about favorable, that even in the 44 months of follow-up, the Checkmate 9ER hazard ratio for survival is standing absolutely at 1.07. Exactly.
Unless the patient is financially challenged.
So if there is no financial challenge, then what will be the medical reasons to give sunitinib in a favorable risk? No contraindication medically and financially for immune checkpoint inhibitors. Then what will be the medical subset of favorable risk where you would like to give sunitinib? Anyone or zero?
I will use immune checkpoint inhibitors combination.
So there is a zero. If they are medically and financially eligible, like they are good performance status and they have no finance problem and no contraindication to checkpoint and others, you would like to use. Okay, Chirag sir, you got your answer.
I will give sunitinib only. And whole world, nivolumab and actinium and cabozantinib and everolimus with lenvatinib and subsequent line of therapy. And that gives me equivalent survival. So why do we give the combo in the first place?
So both of them can answer. Why would you like to give the combo when the patients are surviving same? I gave my reasons that the PFS is doubling, so I gave my reason that it is 13 to 24 months. I'm happy with the patient living for 12 months without disease free, although they are living same. Or they are living, I mean, they're starting at one point and they're dying at one point in a similar way. But I'm happy if 12 months they are happily living and they are tolerating the regimen, of course.
Yeah, I think the tolerance is very important for a low risk patient. If suppose we have a combination regimen which we are comfortable in doing it, then this almost doubling of progression-free survival will be conspicuous for me, and that's probably the reason that I would probably consider using a doublet even in a low risk patient.
Okay. And now what about triplet? Chirag sir is not happy with the answer, but fine. I stand with Dr. Ashish. This is our take on the data. So what about triplet? And this was the stratification, and what was sir talking about is in the all. This was the slide of pembro axitinib again. I mean, these are the, we will, if you concentrate on favorable risk, actually what Dr. Chirag sir was suggesting is that wherever we are concentrating on favorable risk, the confidence intervals are wide, and somewhere like in Nivo Cabo, the discontinuation is going beyond 40% and the usage of steroids is touching 50%. So what escalates the therapy? If you are using steroids, we are even compromised, we are discontinuing clinical investigation. So Ashish, you have already given your comment, whether you would, so here you would like to give a single agent versus combo. Here is a space where you like to give single agent or a combo, and which is the single agent here? Shantanu, you first, and then Ashish has, I think, already said yes.
Sir, combo, sir, because we are unlikely to get much of the data, much phase 3 data anyways for this kind, kind of
then why
patients.
will
So whatever
if you don't have a phase 3 data, then how will we give a combo here?
PFS benefit, whatever we have with combination, I would be happy with it.
Okay. Ashish, which combo?
Pembro accident.
Pembro accident which was presented. Okay. Ashish?
Pembro axo is what I have presented, but the data is predominantly for Nivo cabozantinib. You have a very good data for lenvatinib plus everolimus. That is also a data which is there, and a axitinib monotherapy. In fact, lenvatinib plus everolimus is something which was across non-clear cell histologies.
That is there here. Yes, actually.
Yeah. So I'm actually been using lenvatinib plus everolimus in many of my non-clear cell histology patients. I haven't used IO plus TKI combination in this group of patients.
Perfectly. But what will be your first choice of Monday morning?
So
let
Monday
us say it is type 1 RCC and type 2. There are two papillary RCCs patients. One is type 1 and one is the hereditary fumarate hydrate deficient proven, or no NGS done.
So no NGS done, but the hereditary papillary renal cell carcinoma, I would still have used bevacizumab plus erlotinib.
Okay. There is a data of bev-erlotinib as well as the tizo-erlotinib, and for the type 1 RCC non-hereditary, you would use a combo or a single agent?
I will still use a combo of lenvatinib plus everolimus.
Lenvatinib plus everolimus.
Because that has got one of the best data.
But sir, yes, I will come to this is the data which is one of the largest database. Unfortunately, this is also, I think, only of 100 patients. And this is a SWOG 1500 subset, a phase 2 trial. If you are using a single agent, it has shown that cabozantinib is best because cabozantinib acts on many targets, and MET is one of the target which is very popularly exploited in papillary RCCs type 1. And that is why if you have to use a single agent, it shall be always cabozantinib. And then you can use a combination of Nivo Cabo also if you wish to. And then type 2 RCCs are treated separately. Yes, sir.
So that was the comment which I wanted to make. And for chromophobe, there is evidence of P10 loss, and for P10 loss, everolimus is a better drug.
Yes.
So I will want to use everolimus with lenvatinib.
I think that is one of the best combinations as of today. And then there, even in the guidelines, why cabozantinib is recommended is because of the strength of data. Otherwise, we all have phase 2 data only. I think in the last, I will take 2 comments from the panel. This was regarding Dr. Santosh Menon's inclusions. First was very interesting that I will start with Amandeep. Amandeep, how many patients you are working at a high volume center? And others, if there is any other surgical oncologist who can cover up and help us with this question after you first. Post ICI, do you do nephrectomies, and how is your experience?
Yeah, so our intermediate risk patients who've had a year of immune...
No, neoadjuvant ICI. They have received some sort of neoadjuvant therapies. Neoadjuvant ICI, anything. I mean, not talking
so
about...
our intermediate risk patients with 2 or more factors who were planned for systemic therapy first and then possibly a interval nephrectomy. So if they've had their 1 year of therapy and they've shown a good response, we've had few, not many, I can probably count on my fingers, we've done them. the nephrectomy is not more difficult or easier than any other nephrectomy. It's definitely not more difficult.
And what are your, and how do you response assess? Do you do an, I mean, a PET scan is fine, or a MRI or whatever, do you assess them in the same way as you would do for anything else?
Yes, there's nothing different than assessing.
And what will be that? Suppose on a baseline you do for an RCC, you will do a CTKUB basically.
Yeah, but I think here we do a PET and then decide.
And then you follow up with the PET scan.
The follow-up is done with the medical oncologist again.
But you have to operate, na?
Yes, yes. So the medical oncologist has assessed that the response has been good. Then we discuss in an MDT whether adding surgery to this patient would be beneficial. That PET scan is enough for me to assess
got it. So
effectability.
we will be also, if someone has done a PET scan and there have been a one or two oligo or other, we will be also doing the same scan only. And anything else, Ashish or Shantanu, you would like to add and Dr. Santosh did mention that the pathology is also challenging. It is not only the clinician's problem when you give neoadjuvant ICI in a new disease, and giving neoadjuvant new immunotherapy in RCC is definitely something new for all of us. Shantanu, any comments? I don't have experience of giving neoadjuvant ICI yet in my patient. No experience. Okay. And the next comment, I think that is simpler. We can have comments from all three of the panelists. We all face this, and this was very interesting that we all know the guidelines of doing BRCA testing in breast, as well as we know for colon, doing Lynch and prostate. But as a medical oncologist, we have been more comfortable, and we have been taught, and by heart we remember the breast guidelines like 1 relative, 2 relatives and all that. But Dr. Santosh made a very good comment that how much we are pepped up as a medical oncologist to do that, follow the guidelines for prostate. And here we are talking about prognostication and family history. We are not talking about using our PARP inhibitors in the future. Shantanu, and other histologies, especially cribriform and intraductal, do they make a difference, or you would like any young patient who is fitting the criteria, irrespective of histopathology, to undergo pre-genetic counseling followed by BRCA1-2 testing?
Yes, sir. All young patients with low PSA, particularly low PSA, high Gleason.
Low PSA, high Gleason. Okay.
It's not typical.
Maybe these.
So in fact, that paper also said that the BRCA is histopathology agnostic. So
yes,
that is what was mentioned, I think, Doctor. And so for all young patients, yes, BRCA, yes, but coupled with the genetic counseling, just not writing a BRCA prescription. That's very important.
Amandeep, your comments?
Yeah, so honestly, we don't do it, although it is there in guidelines.
Look, because breast unit, they are all do it, and even now we have also
So the guidelines say for all high risk and for all metastatic, honestly, we don't do it. But if we have to do it, then yes, definitely genetic counseling along with the testing.
But for everyone who fills the criteria of the guidelines, and these guidelines have been issued
Ideally,
not
yes,
by
so I think it is
the
at
South
least
Asian, these are all guidelines from the Western world.
Yes, so
How
I
much
think
will
it is
they
at least
adapt
our job to inform the patient that you are not the routine prostate cancer patient, and we have evidence that we should be doing genetic testing in you, and then I think it's up to the patient also to decide.
Okay, fine. I think we are come to the end. I will just summarize. These were the points which were discussed, and I will just put my comments to it. High risk RCC, I would like to keep them on surveillance, but for sarcomatoid and M1 NED, I would definitely like to discuss about adjuvant therapy. My choice for adjuvant therapy will be pembrolizumab if me and the patient and the tumor board agrees that they shall be treated with some sort of adjuvant RCC. For good risk, definitely single agent sunitinib will always be there on the card, but my preferred combination will be, this is my personal choice and my experience. It is not that one is better over the other. I have been using Nivo Cabo, and it is just about your comfort level. It is not that Nivo Cabo or Nivo EP or Pembro axitinib as well as pembrolizumab. There is erlotinib with BEV or atezo with erlotinib, and this is my take on the data, and of course there will be some ifs, buts and wrongs to this statement. Thank you. Thank you, sir.
Sponsored session on role of apalutamide in prostate cancers.
Good evening. It's a sponsored session, so the content is majority provided by the sponsors. That's the disclaimer. We are here to discuss about apalutamide quickly. It's a new thing which is coming up, and it's important for us to run through the literature for us to have more learned outcome. So apalutamide, it's a next generation oral androgen receptor inhibitor. All of us know 2017 it started with the buzz about it. 18 there was an approval for NMCRPC, and 19 there was an approval for castrate sensitive phase. Mechanisms, it ultimately it's a AR inhibitor, receptor inhibitor. So it blocks the binding, then it blocks the translocation and blocks the subsequent transcription. So same process which we all know about this. Pharmacokinetics wise, so oral bioavailability is fantastic. It's nearly 100%. That's one good advantage. It achieves the Tmax within 2 hours. Generally, food does not have a lot of implications, so it can be taken with or without food. Mean half-life is quite longer, so 3 days. And major circulating compound is circulated in the bloodstream for many days. So up to 70 days, a single oral administration of radio-labeled apalutamide is found for 65% occasions. So roughly the dosage are 240 milligrams. So 4 pills a day orally with or without food. That's the standard thing. It obviously has to be combined with the androgen receptor, the ADT or the blocker or the orchidectomy. So non-metastatic CRPC, typically in India we get a lot of these kind of situations that a patient is diagnosed earlier in castrate sensitive phase, the localized or locally advanced stage, and someone has done an orchidectomy and not treated definitively the local cancer, and then eventually PSA starts rising. That's the common occurrence which we get for all patients, and that's one typical scenario. And second scenario is obviously post-surgery or post-radiation when you have a failure of biochemical recurrence. That will be non-metastatic CRPC when patient is already on androgen deprivation therapy. So rising PSA criteria, serum testosterone of less than 50 by the old norms, and no evidence of any detectable metastasis. So that's the definition of non-metastatic M0 CRPC, and that's the timeline which we pointed out, 2018. So let's run through both the trials. First, Spartan trial for NMCRPC. So they evaluated apalutamide in multi-center randomized manner, a double-blind placebo-controlled trial for patients of NMCRPC. Apalutamide was given 240 milligram once a day along with ADT, and the other arm was ADT with placebo. The inclusion criteria was NMCRPC, but important key line here was PSA doubling time of less than 10 months. So that's very important. So you need to have some serial intervals PSA monitoring. Primary endpoints were metastasis-free survivals, and there were certain secondary endpoints including OS and time for progression, time for initiation of subsequent cytotoxic chemotherapy. Median age 74. So these were the statistics, median statistics. So previous, if you observe this, prior surgery or radiation was about 77. So in India, this possible percentage will be more towards previous orchidectomy done, which is more than 70% probably. So prior treatment with anti-androgen, which is bicolutamide or flutamide, was about 69%. Median PSA of 7.8 and Gleason score more than equal to 7 or above are around 78%. The primary measure, so metastasis-free survival, because it's NMCRPC, so we are looking at metastasis as the primary outcome to minimize the chance of metastasis. So apalutamide plus ADT significantly improved MFS, metastasis-free survival for 2 years, which is 24.3 months versus placebo. The hazard ratio is quite less, almost 0.28, so it translates into nearly 72% reduction in metastasis-free survival. For metastasis, median progression-free survival, symptomatic progression, OS, and initiation of cytotoxic therapy. Majority parameters were significant, and hazard ratios were in the range of 0.20 to 0.70 for OS. So majority of the secondary endpoints were satisfied. Exploratory endpoint was second progression-free survival, and that also had reduction of about 51%. So time for PSA progression, again, that is almost 94%, and if you see the curves, they are almost on different platforms. The placebo curve is almost dipping down immediately, and apalutamide curve is holding. Hypertension, skin rash. Skin rash is one side effect which is very well described for this particular drug, but I don't think it is a very dominating thing in the clinical practice because it can be managed on some antihistaminics. Some few percentage patients having diarrhea, nausea, weight loss. So predominant ones are fatigue, a bit of hypertension, and skin rash. These were the predominant side effects. Similar, I think that just continues the other parameters. So this is about the non-metastatic CRPC phase. Then the second phase of approval was for castrate sensitive metastatic cancers in the initial phase of diagnosis. That's the Titan trial and the investigation. So it's a phase 3 apalutamide versus placebo in patients of metastatic castrate-sensitive prostate cancer receiving ADT. So it's a combination of ADT plus one therapy, doublet therapy. Apalutamide, and it's again the androgen receptor blocker, which we discussed already. Let's understand the trial design. So patients were metastatic castrate-sensitive cancers, good performance status, either 0 or 1. Prior ADT within 6 months. So they were not very prolonged course post-diagnosis of metastatic castrate-sensitive phase. Within 6 months of initiation of ADT, they need to be randomized, and within 3 years of local disease. So again, apalutamide 240 milligrams once a day with ADT versus placebo and ADT. So again here, the primary endpoint will change because this is a metastatic cancer already. So we are looking at OS as the primary endpoint. Against to that, in non-metastatic CRPC, we were looking at metastasis-free survival as the primary endpoint. So here primary endpoints were OS and radiographic progression-free survival. Secondary endpoints were time for pain progression, time for skeletal-related events, time for chronic opioid use, time for cytotoxic chemotherapy, and exploratory ones are again similar, PSA progression. So eligibility, documented metastatic prostate cancer, ECOG 0 or 1, castrate-sensitive phase. Previous docetaxel up to maximum 6 cycles were allowed, ADT within 6 months of initiation, and within 3 years of localized prostate cancer undergoing a definitive therapy. These were the inclusions criteria. Baseline characteristics were almost matched. If you observe the median age, it was almost 68 and 69. They had a fair representation of low and high volume disease, because in this particular space we always think about volume of disease for our decision making. So low volume of about 40% and high volume of about 60% or 62%. Nearly 11% had prior docetaxel, and so Gleason's less than equal to 7 and Gleason more than equal to 8 were about 1/3 and 2/3 proportions. So primary endpoint, radiographic progression-free survival, significant difference, 68% versus 48%. The hazard ratio is about 0.48, so nearly 50% reduction in the risk of radiographic progression or death with apalutamide. Overall survival curves again had a difference after the progression of about 12 to 18 months. Hazard ratio is about, they've not mentioned about it, so 33% reduction in the risk of death because of apalutamide. So OS subgroups, majority parameters will be in favor of apalutamide against placebo and ADT combination, irrespective of the performance status. Bony metastasis presence, yes or no. Visceral metastasis being present, yes or no. The visceral metastasis had, if you see the yes parameter for visceral metastasis, it is not in very much favor of apalutamide, but majority other parameters, disease volume, if you observe high and low, both are almost on the side in favor of apalutamide. So metastasis stage at the diagnosis. Secondary endpoints, again, time for cytotoxic chemotherapy, time for pain progression. Out of these parameters, time for cytotoxic chemotherapy if patient has not received, or time for PSA progressions were in favor. PSA progression happened for 75% versus 36% in favor of apalutamide use. Conclusions, so in patients with metastatic castrate-sensitive prostate cancer, addition of apalutamide to ADT significantly improved survival. Recurrence progression-free survival of 52% reduction in radiographical progression-free survival, hazard ratio of 0.48, and OS there is 33% reduction, hazard ratio of again 0.67. Apalutamide in this setting also demonstrated prolonged time to initiation of cytotoxic chemotherapy if not utilized earlier, and PSA progression and increased PFS2. Apalutamide was well tolerated with adverse events consistent with the previously reported data. So no major side effects apart from the ones which were described, and investigators concluded that the results support the addition of apalutamide to ADT for patients with metastatic castrate-sensitive cancer. So significantly longer OS and radiographic progression-free survival than placebo plus ADT, that is one. Prolongs time for cytotoxic therapy, and second, progression-free survival. Higher percentage of patients in whom undetectable PSA levels were achieved, and longer time to PSA progression than placebo. So PSA repercussions were stronger. Incidence of high grade and serious adverse events did not differ substantially between the groups. Rash is typically the main side effect which is described but can be managed with conservative agents. Incidence of hypertension was lower and ischemic heart disease was higher in apalutamide group in the Titan trial than the Spartan trial. So in conclusion, Titan trial involved patients including those with high volume and low volume disease, previous docetaxel use, previous treatment with localized disease, previously or newly diagnosed prostate cancer within 6 months of diagnosis, and apalutamide plus ADT resulted in significant longer OS and radiographical progression-free survival. The repercussions on recurrence-free survival, progression-free survival were much higher, and OS benefit also did exist to about 33%. Thank you so much. There is one more thing for question answer. So it's one couple of situations which they have given. I'm probably just going to ask it to the audience quickly for the sake of completion. So everything is majoritarily discussed today, but I'm just going to take you through the presentation. So treatment setting, let's talk about treatment settings of NMCRPCs. So probably Amandeep, in your practice, I mentioned about this, that majority of the times in India, we have patients undergoing orchidectomy at the stage of localized disease. It's coming down, the percentage probably are coming down now, but when we were residents, probably we used to see these kind of situations much more often. So whenever these patients present to you with typically rising PSA, they are already castrate. So ultimately, do you qualify these patients into this particular definition? What's the treatment strategy like? Yeah.
And if the PSA is rising, the next would be to image and see if disease is visible. So do
Absolutely.
a PSMA PET scan.
Absolutely.
And if no disease on the scan, then this patient is a non-metastatic CRPC. Yeah. So
perfect. So Dr. Vivek, treatment landscape. So we do a PSMA PET, there are no metastases, PSA is rising, he's already castrate.
Then it comes the role of the doubling time.
Yeah.
So if the doubling time is rapid, he would be a good candidate for apalutamide.
Perfect. Are there any medical oncologists in the group? Dr. Randeep, I think we are the only surgical guys around. So anyone from medical onc here? So how frequently we measure PSAs to qualify? So PSA doubling time of 10 months. Do we actually wait for 10 months? No. So what's the strategy like, and which calculators do we use for a basic calculation or handy evaluation? Right. Okay, and how do we exactly calculate the doubling time for the sake of benefit for all the audience? Are there any calculators which you use in routine practice, or it's right? So it's a estimation based on again. So are you going to be adopting additional therapies beyond ADT or practice?
yeah. So first thing is, I think the proportion of these patients is going to fall as imaging becomes a little more sensitive.
Absolutely, and plus the definitive therapy getting more embarked.
Yes.
And we are not in early 2010-ish.
Yeah.
Right. Okay.
So
So this is for all residents and senior residents. And the guidelines go as we have 20 questions. They are MCQ based. You would be given a sheet. And on that you have to write your name, email ID, phone number and institute. And you will be given 20 minutes. At the end of 20 minutes, we'll be taking away those sheets from you. And based on, there are no negative marking, so please attempt all questions. Another thing, there is a quiz tomorrow also, and the winner will be decided based on both the quiz. So don't give today and miss tomorrow. There are no two winners, no two first prizes. So that's how it goes. Any questions? Maybe we can space out a little bit. I mean, we can, two of you can go behind and also. Anybody amongst residents and SRs who's left behind? I think it's me. So time starts now. It is 7:14. I take your papers at 34. 35.